As of now, total 84,739 cases of coronavirus diseases have been diagnosed in Bangladesh, and the number is exponentially rising daily. At this moment, the routine care to gynecological patients has been hampered, and simultaneously, healthcare providers are also vulnerable to get exposed to COVID-19 infection. As a result, healthcare providers are facing challenges. The objective of today's webinar is to determine the need-based treatment protocol for gynecological cancer patients on a priority base, to develop modification in the existing treatment protocol, and to develop healthcare provider protection guideline during this COVID-19 pandemic situation. This webinar will be a little bit different because there will be answers of some unresolved questions. The webinar is divided into two sessions, gynecological oncology session, which will be followed by obstetrical session. We are delighted to have renowned panel members from Bangladesh and from the UK among us. The gynecological oncology session will be chaired by Professor T.A. Choudhury, sir, President of GOSB and past President OGSB, and the respected panel members are Professor Laila Arjuman Banu, President, Bangladesh Perinatal Society and past President OGSB, Professor Sabera Khatun, Secretary General of GOSB, and ex-chairman, Department of Gynecological Oncology, Bangabandhu Sheikh Mujib Medical University, Professor Ashrafun-Nisa, Chairman, Department of Gynecological Oncology, Bangabandhu Sheikh Mujib Medical University, and Focal Point Cervical and Breast Cancer Screening Program in Bangladesh. Professor Farhat Hussain, Head of the Department of Obstetrics and Gynecology, Sir Solimullah Medical College and Mitford Hospital, and Vice President of GOSB. Respected panel members from the UK for gynecological oncology session are Mr. John Butler, Mr. Adam Rosenthal, Mr. Manhal Nazdi, and Dr. Krishna Shamim Mahadevan. Regarding the gynecological obstetric session, that session will be chaired by Professor Samina Choudhury, Madam, President of OGSB, and the respected panel members from Bangladesh are Professor Samina Choudhury, Professor Roshanara Begum. Samina Choudhury, Madam, is President of OGSB, and Professor Roshanara Madam, Honorable Member of National Technical Advisory Committee of COVID-19 and past President OGSB. Professor Saleha Begum Choudhury, Madam, Secretary General of OGSB, Professor Ferdowsi Begum, President-elect OGSB and President Suffolk, and Professor Triptirani Das, Chairman, Department of Obs and Gynae, Bangabandhu Sheikh Mujib Medical University. Respected panel members from the UK for obstetric session are Mr. Benjamin Black, Mrs. Parveen Akhtar, Mrs. Rehana Yasmin, and Dr. Nadia Sharmin. The webinar will be moderated by Dr. Ashfaq M. Khan, Consultant Lead for Colposcopy and Vulva Unit and Cervical Screening, Whittington Hospital, London, and myself, Dr. Jannatul Firdaus, working in the Department of Gynecological Oncology as Professor, Bangabandhu Sheikh Mujib Medical University. At this moment, I would like to request Dr. Ashfaq to conduct the session. Dr. Ashfaq, please.
Right. Can you hear me now? Is it okay? All right, excellent. A warm welcome from London. It's a bit sunny this weekend, though windy, but I welcome you all and along our panels from England to our friends and colleagues across Bangladesh and elsewhere in the world. First, I would request Professor T.A. Choudhury to give the welcome address to the panel today. Thanks.
Can you hear me? Hello, can you hear me? Okay. First of all, I would like to welcome you all who has joined in this webinar. Initially, the plan was that we will focus on the oncological aspect of women's health during this COVID-19. But ultimately, it was found that since in UK, you have already passed the peak and in the downtrend, we would like to hear from you also how you have managed your obstetric cases. because we are also going up now. We are near about the peak now. So there are lots of things I think to learn from you and how you cope with this COVID-19 pandemic. So I think that is why the second part has been added as an obstetric part of this webinar. So first of all, we'd like to talk on the oncological aspect of women's health during this COVID-19 pandemic. As you all know that because of the endemic, most of our activities in other areas of women's health were kept suspended because the priority was to treat patients who are attacked with corona. Now, nowadays, we thought that the corona is a temporary say, event, but now it appears that it is going to stay with us for quite a long time. Cancer may not be immediately life-threatening, but long-term delay ultimately will actually make the treatment more difficult and less satisfactory. So it is the time now just to open up the urgent cancer treatment in women of Bangladesh. So I think this is going to be not a formal presentation, more like a question and answer interactive session, and we'll try to find out from you also that how you are going to tackle with this problem when we are opening up again. And here also, we would also like to learn, because many of the patients where delay even for a few days or few weeks can make a lot of difference in these cancer patients. So I think I would not take any more time. I would just invite you, the moderators, to conduct the session and let us see how much we can learn from each other. Thank you.
Thank you, Professor Chaudhry. So we're going to start the panel discussion from UK first. As we decided beforehand with Professor Firdaus that this would be a question answer type presentation, no slide presentation, no big lectures. Just we selected the question from our members, our friends and colleagues from Bangladesh. So we wanted to know from them what is their important and burning questions that they want to know from somebody from overseas. And by all means, we are not here to teach anything to any one of us. Every country is different. Every system is different. This is only to express our views, only to share our experiences. Please do not think at all that that we are managing it better than anyone else. So, and you have to listen to our ideas. It is mainly to share our views. Okay, so I'm going to first invite Mr. John Butler. Mr. John Butler is a gynecological oncologist at Royal Marsden Hospital. It's a very famous cancer institute, and it's the tertiary referral hospital in London. His main interest includes ultra-radical gynecological cancer surgery, fertility-preserving surgery for cervical cancer, risk-reducing surgery for BRCA, and also vulval cancer. He has an active research portfolio and has published extensively on gynecological cancer, international cancer survival, and cancer policy. He is the lead clinician for the International Cancer Benchmarking Partnership. He's also a member of the Cancer Research UK Clinical Advisory Committee. Now, John, good afternoon, and thank you so much for joining us. Hi.
Great.
Right. Now, we got from the COVID surge publication that suggested that even the COVID negative patients has got a high mortality even within 30 days of the surgery, up to 25% or so. Now, we are trying to reduce the hospital stay and reduce the complication of the surgery. So my first question would be to you. What steps should be taken to optimize quality of care for gynecological cancer patients during pandemic? Over to you.
So, thank you very much, and it's great to be here and see you all. I think what the coronavirus epidemic has shown is that healthcare and doctors cannot work in isolation. We are part of a system. So I think the thing that I've learned and I've been very impressed by is in the UK, although we have a national health system where systems should work together, that often doesn't happen. But since the coronavirus epidemic, we've managed to really work as teams together. So I think that one of the key learnings that we've had is about the importance of pathway management, leadership, and involving people along all steps of the pathway. So when it comes to gynecology oncology, we work with our other surgical specialties, and it's very clear that you need to think about which patients are the greatest priority for surgery. So we developed a clinical prioritization group, so where we will have 3 big hospitals working together to look at all the cases that potentially need cancer surgery. And we categorize those into patients who need surgery within a week, patients who need surgery within 4 weeks, and then those where their treatment can wait, such as an early stage endometrial cancer. And then we look at the patient's likelihood of cure. So I think to have some form of framework by which there can be equity of care for all patients is very important. So I think the first thing we learned is about trying to build up safe pathways. So if you like, we can have patients where when we have limited healthcare resource, we're most likely to get benefit. And the second thing, obviously, is about conducting safe surgery. And what we did in London, we've got, although we have a national health service, we also have quite a few private independent hospitals which are not part of the National Health Service. So the government immediately requisitioned the services of those hospitals so we could create safe or COVID light or COVID-free cancer sites where we could conduct safe cancer surgery. So there could be a pathway for patients when we've categorized to say who's the most urgent patient to be able to deliver safe surgery in that environment. And I'm sure you'll be looking at it in other places, but in terms of the safe surgery, that's got to be trying to ensure as far as possible that patients do not have coronavirus prior to operating. So for us, we conduct swabs prior to surgery. We get the patient to self-isolate ideally for 2 weeks, but a minimum of 1 week. And if we're going to conduct high-risk surgery, all the patients have a CT scan of the thorax, knowing that just swab testing is not very accurate. So we try and do as much as possible to reduce the risk of patients developing perioperative coronavirus infections. And then in terms of surgical steps, we have been doing, initially we stopped doing minimally invasive surgery because there was a thought that the aerosolization, which means that the spread of aerosol would increase the risk of spread of coronavirus. However, that's probably true for the throat and the GI tract, but not really true for the peritoneal cavity. So we try to minimize aerosolization during surgery, but we have resumed laparoscopic surgery. And the great advantage of minimally invasive surgery is to reduce the length of stay. So I mean, I could go on for a long time, but I think one of the key things is about trying to create a coronavirus safe pathway, both in terms of the hospital infrastructure and also the patients. And then whatever we do surgically, trying to minimize the length of stay. And if you're in the middle of your peak at the moment, it's trying to work out whether it is safer for those patients to have surgery at this point in time, or can that surgery be deferred? So for many of our patients with ovarian cancer, they continued on their chemotherapy rather than having radical surgery. So that's just a flavor of what we've been doing.
Okay, thank you. My next question, is it safe to delay surgery for suspected ovarian cancer? And just give some example where the gynecological cancer, which patient should get the priority for that?
Yeah, so I think it's very difficult when you have, I think in ovarian cancer, there are two sorts of disease. We have the patients with advanced disease, where there's disseminated disease. And for all those patients during the epidemic, we've been getting tissue biopsies and invariably giving them neoadjuvant chemotherapy. The other challenge is with the suspected ovarian masses. And whether we operate on those or we defer their surgery. And if we have the capacity and they're a fit younger patient, then we've tended to be offering them surgery. But we know that the patients, if they were to develop perioperative coronavirus infections, are at greatest risk are the older patients, those with obesity, diabetes, and some ethnic minorities. So we've potentially been deferring those operations. So what we're really looking at is have we got a likelihood of curing this patient, and are the risks of coronavirus, perioperative coronavirus infection acceptable? And certainly we've been, our threshold has becoming lower and lower as we've got a better handle on our safe pathways, but also have greater capacity to operate and when we're through the peak. So one of the key things has been about data collection and audit. So looking at, what are your rates of infection? Have patients had their testing before surgery? And if they haven't been isolated and haven't been tested, should you go ahead with surgery or not? And on the whole, we've been saying, let's defer surgery until we've got a test or we know they've been isolating. The other thing we've been doing, and I'm happy to share any of this, is in our consent for surgery. We offer patients both a standard consent form for surgery, but also a consent form specific to perioperative coronavirus infection. So we've been trying to, as far possible, to avoid intensive care admission, because the intensive care environment is one where, although we try and make it as safe as possible, that's often where the coronavirus patients are. And if we can limit the length of stay in intensive care, that will improve things. So we, for example, initially we were told not to perform anastomosis and do diverting stomas when we're doing radical pelvic resections, but we've now gone back to doing our standard surgery.
Next question, would you share some tips and techniques or precautions that you followed during this surgery in pandemic condition?
Yes, I mean, I think that the biggest change for us was about the preoperative testing of patients and the wearing of full PPE, which certainly has made surgery more challenging with the face masks and visors. Our surgical techniques, so we unfortunately, we haven't been offering training to our juniors and fellows. We've been having 1 or 2 consultants operating to try and make sure the speed of operation is as fast as possible. And for the laparoscopic surgery, we've been avoiding using anything which is going to give a plume of smoke. So we're using something called air seal at the moment, which offers a filtration of small particles, and we're deflating the abdomen prior to removing ports. So those are sort of changes we've conducted. Initially, our anaesthetists had a big gap between the operations. I think we wanted 20 minutes of downtime between the operations, but we've now, you're working with the anaesthetic team, we've had shorter periods between the operations. So I think really the people steering a lot of this are the anaesthetic and intensive care staff, who are under huge pressure, together with the infection control team. So I think it really, the key thing is about teamwork and patience, and not, I know we're often impatient as surgeons, but it is just about taking the time, and everyone is quite stressed and anxious and exhausted. So it's just trying to keep that calm, focused environment all the time. Communication can be quite difficult through the face masks. So you often have to speak loudly. We haven't been doing it, but I've been on some webinars where people have been using Bluetooth earpieces. So that's the sort of thing that might be helpful, but that has certainly been a challenge, some of the communication in the operating theatre.
Right. Okay, thanks. My last question to you is that what should be the follow-up appointment procedure for gynecological cancer patient in COVID pandemic? So how did you follow them up?
So one thing that I think has been out of any time of change, there's always an opportunity to improve things. So we've had team working from teams that never worked together before. But what has massively changed is the ability to follow up patients remotely. I have to say, I was initially against this before the coronavirus epidemic, and now I see great benefits with it. You can involve lots of family members, lots of things you can do by telephone and video. You can share things with patients. You can send them the consent form in advance. They can show you their abdominal wounds. So we've actually been doing many more remote consultations, and it's actually been quite effective. So I think it's I think there is a lot of virtual technology there, and we've managed to do that. And the other thing is, in hospitals now, our MDT and departmental meetings we do through Zoom, and actually we're probably in better contact now than we've ever been before, because before we used to want everyone physical presence, and I find that now we can do things much more rapidly. But I think one clear thing, and I'm passionate about this, whatever we do in oncology, it's about collecting data and collecting outcomes so we know what is happening and working together as a team.
Excellent. Thank you so much, John. That's the end of John's session. Thank you. I don't know whether you can hear that. All right. Okay. Now I'm going to move to Adam Rosenthal. So Adam Rosenthal is consultant gynecologist and lead colposcopy and lead for UCLH cervical screening program. He is also the clinical lead on the UK familial ovarian cancer screening study. He has published extensively on the screening for gynecological cancer and their molecular biology. And Adam, can you hear me?
I can very well.
Excellent.
Can you hear me?
So yeah, Adam, good afternoon.
Great.
And thank you for joining us. And my first question to you is that, do we really need colposcopy during pandemic?
Yeah, absolutely. I think we do. I think that it's been shown to be an essential part of any cervical screening program. It's important in the differential diagnosis of women with symptoms that could indicate the presence of a cancer. And I think of all of the branches of outpatient gynecology, it has to be one of the most important to maintain during a pandemic, if it is possible to do so, depending on your local resources.
Right. Okay, so we have a job then. Now, the next question to you, you know, the LEAP or LETS or cone excision that we do in the theater or outpatient setting is considered to be an aerosol generating procedure in some guidance. And then the question is, how do we then operate? Because we advise to avoid AGPs during pandemic.
So in the UK, we've got some guidelines on this, and for those of you that are familiar with the RCOG website, the Royal College of Obstetricians and Gynecologists, there is a joint guideline written between the RCOG and the BSCCP, the British Society for Colposcopy and Cervical Pathology. And it gives some broad guidance, but isn't completely specific when it comes to the use of different levels of personal protective equipment, or PPE. In general, there are some points which I think it's worth mentioning and discussing. First of all, clearly we should avoid general anaesthetic procedures where possible. So if you have a patient who can tolerate the procedure, it is possible for them to have it done under sedation in theatre rather than with a full general anaesthetic, which of course then makes it more of an aerosol generating procedure. Then as a general point, that is something that you should try to do. In terms of the procedure itself, you should minimize the use of diathermy. So rather than using ablative techniques, you should try to use excisional techniques, because use of ablation or a laser, for example, generates a far greater plume of smoke. Although I would add that, as far as we're aware, the level of the virus in genital secretions is not very high compared to the respiratory secretions, for example. So I don't think people should be too paranoid about it, but I'm sure those of you that are practicing colposcopists will have come across cases where the suction has perhaps occluded temporarily. Maybe a bit of the vaginal wall has got in the way of the opening of the suction tubing close to the cervix. And then you immediately notice the smell of diathermy on flesh, unfortunately. So there's no doubt that however good your extraction system is, there are always going to be certain cases where you're still going to have that smell of smoke in the room. Although clearly you should make sure you've serviced your equipment beforehand and been extra cautious about making sure that the opening of the suction device is well clear of the cervix or the vaginal wall. The fornices in particular, I'm thinking of with the speculum, which has a built-in suction tube. So you should obviously be slow and careful in how you're setting up. Make sure that your equipment is serviced, because a properly serviced suction device that's licensed for use with colposcopy filters down to a size which is smaller than the size of the coronavirus particles. And then I think you should be wearing full personal protective equipment, including an FP3 level mask over the nose and mouth, and also eye protection. Now, it can be very difficult to use a colposcope if you're wearing one of the full visors that goes all the way around the face. So if you have some goggles that you can wear, that would, I think, be much easier in combination with the colposcope. So I think those are sort of the main tips that I would give for it. And again, taking your time, make sure that those who are assisting you in the room, and most of us would work with at least one assistant whilst doing these procedures in outpatients, possibly more if it was in theatre, make sure they also have access to the PPE if possible. If you're not fortunate enough to have an FP3 type mask, then I think you have to make do with what you have available, and be hopefully confident in the fact that you've got a suction setup that's working well, and that the level of virus in genital secretions is thought to be much lower than in respiratory secretions.
Right. All right. My next question to you is that how safe it is now that we defer the treatment for CIN2, CIN3, or stage 1A1 microinvasive disease for 3 months or 6 months during this pandemic time?
So in the UK, we've been regulated in terms of our advice by the National Screening Programme, which has advised that people with high-grade disease should be seen, or suspected high-grade disease should be seen within 2 weeks, ideally, which is the same as pre the epidemic, actually. I think that that's a very difficult target to achieve. Many clinics are working now at much reduced capacity, either because of staff shortages, with staff self-isolating, or because for social distancing and infection control reasons, you simply can't get through as many patients in a clinic as you could beforehand. So fitting these patients in is a challenge for any department in the UK at the moment. And I think that the target, whilst it's very laudable to try to stick to the pre-COVID target, where you've got people with either biopsy-proven high-grade disease or a high-grade cervical smear in the screening program, and you want to rule out cancer as soon as you can, I think it's possibly unrealistic to expect that 2-week target to be achieved. So in terms of how relaxed can you be about it? Well, there's always going to be some cases that will slip through the net no matter what you do, I think. And I think we have to be aware of the fact that we are working in a worldwide pandemic which is affecting every aspect of our lives. And we can't really expect to prevent every single cervical cancer that we would normally be available to. So the first thing I would say is be kind on yourself and your colleagues and your staff. You cannot expect to achieve the same high levels of performance in all aspects of what you do. I think you just have to accept that. The second thing to say is that we know that the majority of women with high-grade smears do not currently have cervical cancer, the vast majority, in fact. If you look in the UK, and of course it's different in every country, in the UK, having a smear of any abnormality at all, the chance of having cancer is only around 1 in 2,000. Now, clearly that risk goes up with the greater the level of dyskaryosis. but the vast majority of patients with a high-grade smear in the UK at least, and I can't comment on the incidence in Bangladesh or other countries, the risk of them having cancer is relatively low, certainly small single-figure percentages. So in answer to your question, I would say that personally, I would think it would be realistic to see patients with high-grade smears as soon as you can practically, but realistically, if there is a delay of 3 months, it is not very likely that the overall outcome of that patient will be worsened. If you have a patient who's got microinvasive disease on a biopsy, then assuming that you have had good visualization of their cervix, and preferably if they have a type 1 transformation zone as well, so what you see is what you get, you have been able to review the thing, view the lesion as an experienced colposcopist, and you're pretty convinced that there's no macroscopic invasion there, then again, the chance of a case like that having a significantly worse overall outcome, even if you delay by a few weeks, is unlikely to be the case. But clearly, once they've got microinvasive cancer, the patient is going to be extremely anxious, and you are going to want to get your definitive diagnosis, which after all can only come once you've done the formal excision, because you cannot assume that just because your cervical biopsy is microinvasion only, that there isn't a greater degree of disease hidden from you deeper in the specimen.
Excellent. So I'm going to finish your session there, because we're going to move on to the next panel member. But thank you so much for your time. Thank you for sharing your experience with us. Thank you.
It's my pleasure. Thank you, Ashfaq, and thank you, my colleagues.
All right. So the next person I'm going to invite is Mr. Manhal Nasdi. He's a young gynecologist who has special interest in gynae oncology. He's currently working in the Guy's St. Thomas Hospital, which is also a tertiary referral gynae oncology center covering mainly south of London. And he's actively involved in the patient management and gynecological oncology surgeries during the pandemic. So Manhal, good afternoon. Can you hear me? Can you unmute yourself? Unmute.
Hello, good afternoon.
Excellent.
Thanks very much.
Right, excellent. So my first question to you is mainly about so we covered a little bit of ovarian cancer and that, and then cervical. We want to talk to you about something related to endometrial one. So postmenopausal bleeding, which is now considered to we all consider to be a high risk for developing endometrial cancer. Now, what was the usual? We know the usual care pathway for endometrial cancer. They have ultrasound scan, they have hysteroscopy or biopsy. Have you noticed any sort of change on this pathway during this COVID time, and without compromising the patient's safety?
Well, yes. Well, thanks very much, first of all, for giving me the opportunity. And yeah, as much as I feel privileged to have such great speakers, Mr. Butler and the team, I'd have to figure out that I was involved during this pandemic time in the rapid access management and the one-stop strategies. And in fact, you could possibly consider this as the front line related to the gynecological oncology practice. So it was absolutely necessary to merge the rapid access clinics and the gynae oncology interest consultants in the units within the UK with their peers in the multidisciplinary team to get hands on the risk assessment, risk stratification, understanding the strategies of how surgery would work after the triaging. And then the British Gynecological Cancer Society had, and the national guidance had advised really that during the pandemic, the management should run along the lines of triaging patients. And in fact, given Rapid Access Clinic is already a triaging service, but that had also involved a lot of non-relevant referrals, which now need to be very relevant to try to avoid the exposure of elderly patients who would present with the postmenopausal bleeding, as you correctly said. It represents at least 8 or 9 out of 10 of every referral to the Rapid Access Clinic. But we all knew that at least 80 to 90% would have non-cancer related or non-pathology, endometrial pathology related causes. And based on that, the team, and following the national guidance, had advised that the diagnostics, really, the diagnostic service need to be triaged. And that had involved standard questions that we started when we ran through the virtual clinics, having patients get seen in the primary care, they get referred as the routine guidance, and then they get further questions about risk stratifying, whether these patients, first of all, we had to ask questions whether those patients were clear of COVID, whether those patients had symptoms of COVID and had been tested for COVID. We also asked questions related to risk factors for endometrial cancer. So it was crucial to understand whether this patient had high body weight, BMI, whether they have been involved in any familial cancer syndrome, and whether those patients had been nulliparous. And then based on those risk factors, we kind of organized the strategy of the referral. There has been a change to the pathway and the 2 weeks referral. And I'll have to admit that the triaging services and the diagnostics had a massive benefit from these triaging clinics. Although we were expecting that the cancer diagnostics could start falling and patients would avoid coming to hospitals, we have actually found that the patients at home had perceived the phone calls very quietly and quite positively, because basically most of the elderly patients and families would avoid coming to hospital. But when we approach them by phone, once they report their symptoms to GP and explain to them the numbers, the risk stratification. For instance, the strategy used to be that we'd refer them to an ultrasound scan given when we give the history of postmenopausal bleeding. If we know that they are asymptomatic and there was, for instance, a significant thickness in the lining of the womb at a postmenopausal woman, we would explain to them that the risk of having a sensitive pathology in the lining of the womb becomes less than 3% versus 10% when they are symptomatic and they have thick endometrium. And then we would offer them the uncertainties that we are facing from the morbidities they have, and whether that would expose them to the risk of contracting the virus. Our uncertainty whether when contracting, or if possibly contracting the virus, on their attendance to hospital is more likely, is more of on the top of the agenda, versus they would like to exclude the cancer process.
So that means, is it, sorry, Manal, I just interrupting you because for the time reason.
Please.
So is it possible, I'm thinking of in a country or an area where the resource and the capacity is not adequate, is it possible the postmenopausal bleeding patient we can avoid hysteroscopy completely and defer it, or do something in the meantime for a few months and do it later on?
So what we're practicing at the moment is we advise patients who come in. If your question is to do whether we can avoid hysteroscopy all in all, then I think this can be something that could be considered for patients who would have a one-off episode of bleeding, a minimal episode of bleeding. But for patients whom are really, really symptomatic of bleeding, I believe we still had advised them to come into the rapid access clinic to get a hysteroscopy. I understand that the challenge when they have a hysteroscopy, a diagnostic tool, and whether they would be contracting the virus is still not negligible, but it's far more less than a hospital admission for a big procedure. And the difference in our practice has been that once we have obtained the tissue diagnosis, and once the multidisciplinary team had advised for a treatment, the first recourse has always been to consider Mirena coil and progestogens. There has been evolving evidence, even prior to the pandemic, that we could offer those patients Mirena coil and progestogens with a view of revisiting the pathology every perhaps 3 to 6
how much
months.
progesterone do you suggest?
At the moment, we advise 400 milligrams according to the number of RCTs that and the level of evidence from the BGCS advice. 400 milligrams twice a day, alongside with an insertion of a merino coil.
Excellent.
Now, the interesting thing is that we used to, once we do the hysteroscopy for the tissue biopsy, and depending on the level of expertise of the hysteroscopist, we used to offer and discuss with the patient the insertion of a merino coil at the time, because that would save this patient another visit, technically, by just sending a virtual prescription of the progesterone should the diagnosis come back as an early stage, early gate endometrial cancer.
Okay, excellent. My last question to you, and that's for the trainees and the junior doctors who are assisting a gynecologist, the theater staff who are around them. And there's a lot of panic, a lot of anxiety that whether I should be there, whether I should just hang around or not. Can you share your experience in short? Just what did you notice in last 2 months when you were performing the surgeries, the safety of your assistants and the nurses and the theater staff? Yeah, Manav, you can start.
So basically, well, basically,
Can I have
sure
a question, please? Can I have a question? I'm
Of course.
I'm Dr. Khurshid Jahanwala, gynecologist, president-elect in
Madam, can I take the question at the end, please? Is that okay? We finish this session, then I will take the question, if you don't mind. Okay, thank you so much. Yes, Manav.
Thanks very much. So you will have been aware that there has been redeployment for junior doctors and trainees in obstetrics and gynecology across the UK have been focused really on giving the emergency services at maternity and the cancer services, given the cancer surgery had to continue. And of course, there has been a lot of anxiety and the way we got over this is we arranged simulation sessions and teaching sessions on how to deal with things. And that was the case in outpatients and also in theatre. So for instance, we arranged sort of a food pathway, as in a one-way pathway for patients and for junior doctors when seeing them. PPE has been a big problem because of the availability. And of course, we had to reassure patients and reassure junior doctors as well that the use of PPE is good to help. But I mean, there has been enthusiastic candidates who would believe that it wouldn't be fair on a cancer patient that a service provider, for the fear of the contraction of the virus, shouldn't go ahead and do the surgery. And that's why the national higher medical authorities had instantly supported us by PPE and has put things in line, as Mr. Butler had initially explained, that there would be a time limit before you would enter theatre. You should be in full PPE. You have to gown with a fluid repellent gown. You have to double glove. The communication will need to be limited to the most essential communication. And then the way you go into theatre the doors should be completely different from the exit doors, and you have to take off your PPE. Doing such has given confidence to our junior members of the team to join, because when we all started, as Mr. Butler had explained, the surgery has been in COVID clean units, which I believe is very determinal and very reassuring. Like, if this is something the resources over there in Bangladesh would help, then I for sure would advise a COVID clean environment for gynecological cancer surgery is likely to help give confidence and maintain the pathway.
Thank you so much, Manav. Thank you.
Thank you.
And I really appreciate your contribution and the time that you've given us today. And so I'm going to move on to next person, and thank you. Right, so the next person I'm going to, again, I will take questions very briefly. If possible. But I want to invite Dr. Madhvan.
Hello.
Hi, Madhvan. Hi.
Hi.
Thank you. So Madhvan is actually consultant clinical oncologist with a special interest in gynecological oncology. He's also one of the person who actually set up the Southern Cancer Center, which is covering the whole area of the Essex part. And he is also a clinical lead for Essex Cancer Research Network. And he also an advisor to the NICE, which is a National Institute of Health and Care Excellence. Right. So, Madhvan, I don't know. I mean, I know from the MDT you meet us a lot, but today is slightly different. So I want to ask you that with the possibility now that all the cancer surgeries now, most of them are now been suspended. Now the radiotherapy or chemotherapy is playing a very important role now. I mean, a lot of places it's been advised that, okay, let's push it to the radio oncologist and deal with it rather than bring the theater. So my question is, first question, I've got a couple of questions to you. In some guidelines, it's suggested that radiotherapy should be given in hypofractionated dose to reduce the number of visits. Is it something suitable for the gynecological patients, especially the cervical cancer?
Sure. Thank you very much for that. Look, for cervical cancers, it is very, if you're treating them with curative intent, it is really impossible to hypofractionate any more than 2 or 3 fractions less than what you would give. So it's not meaningful. And you need to make other mechanisms to reduce number of visits. What we can do in the palliative setting, which we've done, which we've moved massively, is for vulval cancers, recurrent vaginal cancers, locally advanced cervical cancers, we've hypofractionated. And if we were to give, 3 weeks of treatment, or even 2.5 weeks, 36 and 12, we've given single fractions. And I've given, for example, single fractions 2 months ago at the start of the whole COVID closing down. And I've seen these patients, an exceptional response that you see with single fractions. Now, this is the sort of thing we were doing 20 years ago before conformal radiotherapy and IMRT. We were giving single fractions for palliative purpose, and we gave that up in time. And we're realizing that that is so valuable and it will stay even post-COVID. So the palliative treatments, it is an effective, it's a good bite of the cherry there to treat them with single fractions, 2 fractions in the palliative setting. The curative setting, it is hard. In cervical cancer, the only change that we made in the treatment of cervical cancer, well, 2 changes. One is to exclude chemotherapy as much as we can, and we did, because if a patient has toxicity there, they're admitted, and at the peak of the COVID time, the chances of getting infected was very high. We reduced the number of brachytherapy theater attendance. So we had 1 application with 3 fractions, which is given a morning, evening, and the next day morning, rather than 3 separate weekly fractions that we're giving. So these are the changes we made to reduce visits. I think at the start, our supply chain, which is you guys, the surgeons, was still doing COPs and surgery, and patients were coming through, and we had to think very fast. Not just because we had to treat those patients, we were 30% down on radiographers because they were self-isolating. We were down on chemotherapy staff. And that's the big danger in all hospitals, because unlike surgery, we can't move out to a COVID-free area, indeed a COVID-light area. We have to stay within a big general hospital, which is porous, And these changes have to be made, reducing the number of visits by really reducing fractions in the palliative setting, avoiding chemotherapy.
And is there any role you can suggest, like a vulval cancer or early endometrial cancer or so, where we try to avoid the surgery? Do you think that your team can play a role there?
Look, for endometrial cancer, that is a big problem, because trying to treat endometrial cancer radically with radiotherapy alone is, you are subjecting the patient to 6-7 visits to 6-7 weeks of visits to hospital, and then brachytherapy. And actually, it is counterproductive. You're actually exposing the patients significantly. And these patients have comorbidities. They are high BMI and comorbidities, and they are at risk more than anyone else. And delaying or indeed not giving treatment till after COVID wouldn't be unreasonable. For vulval cancers, we've had a good group of patients who we did not treat. And what we did is we had clinical measurements at the start. We had an MRI at the start. And then 2 weeks ago, I've seen these patients with not a lot of change. And as long as you are open to both a telephonic consultation and keeping an eye on them, not treating them wouldn't be an unreasonable position to take for these sort of patients. For cervix, it's the only one we didn't compromise. No compromise at all, you know.
Yeah, okay, that's very helpful. Madhavan, thank you so much for your contribution today. And
thank you very much.
We all appreciate. And before I conclude this session, I just want to take one question only from Professor Maula. She is the president-elect for Bangladesh Gynecological Oncology Society. Professor Maula, your question, please.
Thank you, sir. My event was passed on. Even then, I asked to the previous speaker that during this pandemic session, how he is managing the cases, operable cases other than surgery. I am asking that question.
Okay, so have you got your answer by this time?
Yes, I have.
Okay. All right. Okay. Thank you so much.
I have got my answer. Thank you.
All right. Excellent. Now,
can
I that's excellent. That's the end of the session for gynae oncology from the UK. I want to personally thank John Butler, Adam Rosenthal, Manal Nasdi, and also Krishna Swami Madhavan. Today, I would say that unfortunately for us, because it was a nice weather outside, I was feeling bad because it's very rare for England. So it was a sunny afternoon. And thank you so much for giving up your afternoon for us. I'm sure that all our colleagues back in Bangladesh definitely will appreciate your contribution. Thank you so much.
Thank you.
Over to Professor Firdaus.
Thank you, Dr. Ashfaq. Before going to start my next session, here are some beautiful virtual water lilies from Bangladesh as a token of appreciation for giving us time for the gynae-oncology panel. Thank you very much. So I like to start with the gynae-oncology session, Bangladesh chapter with Professor T. Choudhury, sir. Sir, COVID-19 pandemic has impacted many sectors, including the education sector. During this lockdown situation, many of us rely on e-learning and social media for teaching and learning. So my question is, first question actually, sir, how can the academic activities and research activities be carried out in this crisis period? Sir, you are muted. Unmute করে নেন, sir. Unmute করে নেন. Unmute হয়নি, sir. Please unmute.
Can you hear me?
জি স্যার, শোনা যাচ্ছে।
শোনা যাচ্ছে।
জি স্যার, we can hear.
Thank you for your question. But I have been teaching students for a very, very long time. And our traditional teaching had been just a face-to-face teaching. As Sir William Osler said, that unless you put your hand on the body of a patient, it is nearly impossible to diagnose a particular disease. But time has changed. Now we have got newer and newer modalities of diagnosis, particularly newer technologies. Now, this is not the time actually for this discussion. I think it should come a little later on after we have recovered to some extent from this pandemic. We are not thinking very much about the teaching now, but what happens that we cannot defer it indefinitely. And what undergraduates, we have to take care of them. So now we are switching off. Now every dark cloud has got a silver lining. And I think pandemic of COVID-19 has an opportunity to arrange these online teaching programs. It was there, but we did not utilize it to the same extent as it could have been utilized. Now, as time goes on, we recover from the assault of this COVID-19. I don't think we'll go totally back to our clinical medicine, but the best thing will be just to interlink this online teaching with the pure clinical teaching. Lots of things that we teach with the students in the world can be taught very well by this video conferencing. But at the same time, this video conferencing does not exclude the possibility of face-to-face contact, the touch of the patient's skin, the pain she feels, and sometimes just looking at the patient face-to-face, you can detect many clinical things which you cannot do by a video. So I think our next program for teaching and training of our undergraduates and postgraduates will be that we'll try to blend both face-to-face teaching as well as the remote teaching like video conferencing. And I think if we can just use these two technologies efficiently, I think our students will get benefit. I think this is one of the unforeseen benefits of this COVID-19 infection.
Thank you, sir. Sir, rightly you have mentioned that we have to blend our knowledge with the touching of patient. So next question to you. Sir, we know that the incidence of endometrial carcinoma is highest in the developed countries, but nowadays in developing countries, also in Bangladesh, the incidence of endometrial carcinoma is also increasing, but there is no screening protocol. Do you suggest to give prophylactic progesterone in patients who are at high risk of developing endometrial carcinoma?
As a matter of fact, science says that you do not give any treatment empirically. How do you diagnose? It has to be a tissue diagnosis. Now, once it is diagnosed, then comes the question of therapy. But if you have not diagnosed, I think there's no scope for giving progesterone therapy only on the basis of suspicion. Now, in these cases, as our previous speaker has said, that we try to avoid surgery as much as possible. Ultrasound is a very good alternative, but you have to have a very good ultrasonographist to give you a correct opinion. And unfortunately, they are not very easily available. And the machine's resolution has to be also very good. So I think ultrasonography should be our first chance. And if we found that the endometrial thickness is more than what it should be, or if we find a irregularity on the surface or breakdown of the surface, or we get a polypoid growth, I think this can be done. And if necessary, we can do a hydro sonography also if the lesion is not very visible on regular ultrasonography. Now you have got 3D, 4D ultrasonographies also. So I think ultrasonography can give us a good idea about the possibility of malignancy. If there is no possibility or the chances are very small, even then I would not give long-term progesterone therapy, but see if she's having bleeding problem, just to control that bleeding for the time being. I think we have to go back to the cellular diagnosis also, because nowadays we know that endometrial cancers can be diagnosed if you can do a sort of liquid-based cytology, and you can use a sort of brush which is not very invasive, and that can also be the second stage by which you can diagnose. All in all, I'm not in favor of giving prophylactic progesterone unless I have got cellular diagnosis. Thank you.
Okay, thank you, sir. Thank you very much. My next question to Professor Laila Arjuman Banu, Madam. Madam, we have seen that in recent years, laparoscopic surgery has rapidly developing and causing a revolution of surgical management. And you have a lot of experience in this regard. My question is, in different guidelines, it has been recommended that laparoscopic procedure should be changed to open procedure. And what is your opinion regarding this? Madam, আপনি mute হয়ে আছেন, unmute করেন.
Centrally muted. Is it okay now?
We can hear.
Thank you very much for this question. Actually, I have gone through many guidelines like your Asian Society of Gynecologists and International Gynecological Cancer Society, the American College of Surgeons, ACS, and also FIGO and RCOG. Except FIGO, all the guidelines are saying that laparoscopy should not be done in case of gynecological oncology, because there are some problems like higher rates of recurrence. There is circulating carbon dioxide, patient selection technique, and worse survival. Only it is recommended for en-bloc dissection and if the tumor cutting or spill is not done. So it has become very limited. But before few years, we used to do the radical hysterectomy for cancer cervix and other pelvic clearance for other indications. But nowadays it is slightly discouraged. But in FIGO guideline, they have told that before starting or restart the surgery, you can have the laparoscopy because it is time is less and only the stay in the hospital is less than the laparoscopy. So there is still some controversy, and actually I have still doing laparoscopic hysterectomy last 3 or 4 weeks I am doing, but the result is not bad. The result is good, no complication occurred. So I think it depends on the center to center and also the surgeon's motivation actually, what he or she think that whether it is safe or not. But both the points are very much strong. And for laparoscopy, I think this is the opinion about the laparoscopy.
Okay, thank you so much, madam. That means it depends on institutional protocol and also resources, availability of the resources. Okay, madam, my next question to you. We know that the physical examination is very important for the diagnosis of gynecological cancer. But during physical examination, there is a high chance of getting contamination of coronavirus. Do you take extra precaution during doing physical examination, especially vaginal examination?
Yes.
What is your experience, madam?
Good question. Actually, I was attending my chamber for the last few weeks. Last week, I just started my chamber. But during attending the chamber, I get PPI, face mask, and also the headgear to examine the patient. Without examining the patient, you can't diagnose even. So I think during examination it is very important. For our junior colleagues, they don't want to do the examination and the participation examination, but participation examination one thing I want to add that before starting surgery, because my question, before some points we consider, like do you mute your audio?
Madam Khushijan, Maula madam, please mute your audio. Okay, thank you.
In prioritization, already I think it is mentioned by previous speaker, it is very important, and you should establish a prioritization policy committee in your hospital before we start your surgery, and also other facilities you should know. Whether you have, there are 10 points described by the American College of Surgeons. You should have this adequate staffs, you should have logistics supply, you should have PPI like this. And when all these are fulfilled, then you can restart the surgery. Because in many countries, still the surgery is not started, especially where there is no green zone. And the Bangladesh, there is no green zone now. So in some part of India, they started the surgery in green zone, but we can't start. I have also discussed this matter with the president of our laparoscopic society, the surgical laparoscopic society, and they also tell the same thing. Because if as we have no green zone in our country, so at this time, at this situation, we can't start. or surgery. I think 2 or 3 weeks we may need to have some green zone in our country.
Okay, thank you so much, madam. My next question to Professor Sabira Khatun, madam. Madam, you have many years of experience to work in a high volume center that is in Bangabandhu Sheikh Mujib Medical University, and you worked with large number of patients, with GTD patients, that is gestational trophoblastic diseases. So I want to hear from you, can we start prophylactic chemotherapy in patients with GTD to reduce the number of visits, and how the follow-up of GTD patient be successful by telemedicine during this pandemic?
Thank you, Professor Jannatul Firdaus, for asking me this question, because I have worked with GTD patients during last 20 years. And GTD, everybody know that it is a early pregnancy related complication, and two types of GTD: complete mole or partial mole. And among this gestation, complete and partial mole, complete 15 to 20% of the complete mole can undergo change to choriocarcinoma or invasive mole, but only 1 to 2% of partial mole can change. So for the earliest diagnosis of choriocarcinoma or partial mole, it is the key to the diagnosis is to follow up of the patient by weekly beta HCG and by other investigation. So the usually GTN, we know we call GTN, that is choriocarcinoma invasive mole. Usually GTN develop from the high risk group of patients, mostly high risk group of patients. Only 1% low risk group of patients can develop GTN, and the high risk group of patients are prolonged post-molar evacuation, bleeding, thecal uterine cyst, everybody, uterine size, large uterine size, beta HCG more than 1 lakh, and acute pulmonary insufficiency, and second molar pregnancy, that is recurrent molar pregnancy, and age of the patient is also important. These patients are high risk group of patients, and use of prophylactic chemotherapy for this high risk group of patients to reduce the incidence of choriocarcinoma or invasive mole, and is given in a single dose of methotrexate or actinomycin immediately before evacuation or during evacuation or immediately after evacuation. And the different data have shown that the development of the GTN in this group of patients using prophylactic chemotherapy can be dropped down from 20% to 10%. So, and other patients for prophylactic chemotherapy are the non-compliant patient. That is, follow-up is the key for the diagnosis of GTN. So some patients may not come for follow-up. So non-compliant patients are also the candidate for prophylactic chemotherapy. In this regard, I have gone through many literature. I have in the literature, it is found that many of the studies I have done, that among them the 8 case control and 3 randomized control trial during the 68 to 2009, that analysis of these studies have shown that the use of prophylactic chemotherapy can be substantially reduce the development of choriocarcinoma or invasive mole. So the question is, and toxicity. The question is the toxicity, development of toxicity from chemotherapy. Whether we will go for the toxicity development in this patient. But toxicity development is not so high. It is only 5 to 10%. So in 2016, Cochrane Library analysis of 3 randomized control trial have also concluded that the prophylactic chemotherapy can reduce the risk of progression of GTN in high risk group of patients. So prophylactic chemotherapy, but they have not concluded about the follow-up of the patients. Your question is whether follow-up interval can be reduced by using prophylactic chemotherapy, but they have not concluded about the monitoring and follow-up of the patient, whether it can be reduced. But the development of choriocarcinoma and invasive mole is greatly reduced. There are some other problems with use of prophylactic chemotherapy. There may be delay in diagnosis of GTN, and there may be development of drug resistance. These are some drawbacks in the use of prophylactic chemotherapy. With this background, your question is whether we can use prophylactic chemotherapy in Bangladesh to reduce the number of follow-up. In this regard, I want to say that in Bangabandhu Sheikh Mujib Medical University, during last 15 years, I have followed the 700 cases of gestational trophoblastic disease. Among them, the ideal schedule is weekly follow-up of GTD patient by beta HCG. But in our patients, in our 700 patients, we have did the follow-up 2 weekly instead of weekly follow-up. But development of GTN in this group of patients was normal. That is 10% only. It is normal. 10 to 20% is normal. So there was no more chance of development of GTN in this group of patients. So in this regard, I want to say that we can give prophylactic chemotherapy in the high risk group of patients only, not in the low risk group of patients. But prophylactic, before giving we should thoroughly evaluate the risk factors of the patients. Risk factors, without evaluating the risk factors, but evaluation of risk factors is very meticulous. It starts from the sonographic report during evacuation, height of the uterus, size of the ventricular utensils, beta HCG level. All this should be considered to consider a patient as a high risk group of patients. So we can give prophylactic chemotherapy by which the number of follow-up interval can be increased. And the prophylactic chemotherapy, as there are a lot of studies about the prophylactic chemotherapy for GTD cases, we can give prophylactic chemotherapy to increase the interval of follow-up, by which the exposure of these GTD cases can be reduced, and the visit of the patient, exposure of the physician to the patients can be reduced. So in this situation, pandemic situation, it can be considered prophylactic chemotherapy for the high-risk group of patients only.
Okay, thank you, madam. For the high-risk group of patients, we can suggest prophylactic chemotherapy. Madam, another question: in a certain guideline, it has been recommended to use neoadjuvant chemotherapy in cervical cancer, and you have also experienced regarding that. You have conducted many research. So, what is your suggestion regarding the use of NSCT in cervical cancer in Bangladesh?
Use of NSCT in case of ovarian cancer is well established and well recognized. But use of neoadjuvant chemotherapy, NSCT, for cervical cancer is still questionable, and it is one of the options for the use of NSCT in the stage 1B2. Stage 1B2, that is when the size of the tumor is more than 4 centimeters. But your question is whether when the size of the tumor is more than 2 centimeters, whether we can use the neoadjuvant chemotherapy. And in this regard, research started in 1980. Piloting was done in 1980. And since then, numerous research work has been done in this regard, use of neoadjuvant chemotherapy in case of cervical cancer. And use of effect of neoadjuvant chemotherapy is very pleasing. That is, it reduces the pelvic and the distant recurrence. It reduces the parametrial invasion. It reduces the lymph node metastasis, and progression-free survival is increased, and the resection, mostly the resection rate is increased, resectability of the tumor is increased. But overall survival, whether by using the neoadjuvant chemotherapy in cervical cancer, whether it increases the overall survival, it is inconclusive. So the use of neoadjuvant chemotherapy is in this regard. I have gone through many research, many studies. Among them, the 3 Cochrane database systematic review was done first in 2010 in London, and that report shows that it is positive benefit for neoadjuvant chemotherapy. And second Cochrane database analysis in 2012 also showed could not conclude the overall survival of the patients. And another guide, German guidelines show that the neoadjuvant chemotherapy for cervical cancer can be given only for the high-risk patients, those high-risk patients who may need the adjuvant concurrent chemotherapy. So that is post-operative adjuvant chemotherapy. To reduce the use of adjuvant, that is post-operative concurrent chemoradiotherapy, high-risk group of patients can be given neoadjuvant chemotherapy. So the third Cochrane analysis was done in 2019, and they concluded that the neoadjuvant chemotherapy followed by radical surgery is an acceptable, promising, and alternative way of surgery for those patients, for those cases having the tumor size more than 4 centimeters. But in this case, your question is whether in case of tumor more than 2 centimeters, we can use the neoadjuvant chemotherapy. And now the question whether we can make a research protocol. I think that it has been recognized, and the guide of IGCS, International Gynecological Cancer Society, is to give neoadjuvant chemotherapy in tumor more than 2 centimeter size. So in this COVID-19 situation, to reduce the exposure of the surgeon, to avoid this high volume surgery, and to avoid the exposure of the OT personnel to the patient and the COVID, that this can be done. So research work. So definitely as there are lot of research regarding this neoadjuvant chemotherapy in case of cervical cancer, when the size is more than 4 centimeters. But in case of 2 centimeter size, as there is recognition of IGCS as a guide to use the neoadjuvant chemotherapy for this patient, so it can be used. Research work can be done. In this regard, I want to say about my research work I have done in Bangabandhu Sheikh Mujib Medical University in 2016. Among the 40 patients, we found that the partial complete response was in more than 90% of the patients. And the response was very good, and the resectability was very nicely, resectability was obtained, and duration of surgery was reduced. So it has some benefit. And by this using now in this COVID situation, by using neoadjuvant chemotherapy in these patients, we can extend we can avoid the exposure, and as well as we can extend the waiting period of the patients. So that 3 cycles of neoadjuvant chemotherapy before surgery, by this time the pandemic situation may be covered up, and we can go do the surgery, or otherwise you can send the patient for the adjuvant radiotherapy. Now,
thank you so much, madam. Your suggestion is we can use it in selected group of patients.
Selected patient, but before using, before taking any research work in this regard, attention should be given to the ethical clearance of before taking any research work. We should identify the high-risk patients, and the ethical clearance is very important, and the decision should be taken in a tumor board.
Okay.
Otherwise, otherwise will not the research will not be possible. So first of all, tumor board decision, then ethical clearance, then identification of high-risk patient. So by this precaution, we can take a research protocol. We can make a research protocol to do a research work on this cancer patient more than 2 centimeters in diameter for neoadjuvant chemotherapy.
Okay, madam, thank you so much. My next question to Professor
Dr. Janaki, can I have a question?
Madam, please, we will finish our session, then we take your question, Madam, please. My next question to Professor Ashraful Nisa. Madam, we know that cervical cancer screening in Bangladesh is being implemented since 2004, and you are the focal point of that. But routine screening have almost been postponed during this pandemic situation. So how can we restart cervical cancer screening during this pandemic situation? Do you suggest any new model or strategy? Ashraful Nisa, Madam, please. Mute হয়ে আছেন. Unmute, please unmute.
Okay. Hello. Thank you, Dr. Firdaus, and also thanks to the learned audience. We know that Bangladesh is running screening program that is VIA based, and we have about 464 centers at the moment at primary, secondary, and tertiary healthcare level. In the primary healthcare level, we have about 300 centers also, and all are now routine screening is actually almost not going on at the moment. And we have a target population of 22 million, and we have screened only 2.4 million population that target group. That means the screening coverage is only 10%. And for evaluation, we do colposcopy in about 20 centers, tertiary centers, and we use lip and thermal ablation for treatment. Now, to start the screening, actually, thing is that RCOG and BSCCP guidelines do not recommend routine screening during the pandemic, particularly to avoid the face-to-face contact. However, if the pandemic is like this continued for a long time, or if it persists as endemic condition for 1 or 2 years, we should start the routine screening. And for that, what we are thinking that we will take the appointment first through the telemedicine, because then what we can do that we can counsel them through the video conferencing. We can counseling is very important, and we can counsel also the family, and we can take a medical and reproductive history, detailed history, and after that we can select the patient, select the target group, and then we can register them electronically with the national ID, and then we will give them appointment to come to the clinic. Obviously, we should not forget that many patients come to the screening center without appointment from far places. So we have to consider that as well, side by side. And again, we have to keep the number of patients minimum for each day. And also attendance should be discouraged, because that sometimes make bulk of people in the clinic. So, and also on entrance, we have to check temperature, and also we have to ensure mask, hand washing, and social distancing, everything, and then we can allow them for routine screening. Now, about the asymptomatic women and for routine screening, it's very difficult to get PP for everybody. So, but at the moment we have just started initiating some routine screening, and actually my doctors and nurses, they want to use the PP. So you tell me whether it is feasible to use PP for routine screening. That I don't know, but at the moment they are using PP. And we are trying to maintain a database also. We have started keeping electronic data for each woman recently, and we are trying to do that. And regarding treatment, actually, we are not doing colposcopy for low-grade lesion at the moment, and we are just telling them that to come back after 3 months. But recently we have done some leave to leave for treatment. They are actually they came just in the initial part of pandemic, and we said that okay, come back after 2 or 3 months. But it's long time now, so we have done 2 leave, and we have done several thermal ablation also. I don't know whether actually leave or thermal ablation, which one is more safe to practice. I mean, both may spread a very low level of infection, maybe if obviously if the patient is positive, but routinely we don't know, don't do the COVID test for the asymptomatic women, so we don't know actually what is happening. And so basically we are seeing the high grade patient for colposcopy at the moment, not the low grade one. And we haven't handled any COVID patient anyway in the clinic, so we don't have any experience on that. So this is just some learning about the managing this pandemic period, and we have to learn more. We have to manage more. Thank you.
Thank you, madam. Thank you so much. Now I want to move to Professor Farhat Hussain, madam. Madam, you have a lot of experience dealing with ovarian cancer cases. So we know that actually in ovarian cancer, surgery is the mainstay of treatment. But during this pandemic situation, would you like to perform surgery in all type of ovarian cancer? I mean, which type of ovarian cancer should get priority for surgery? Madam, mute হয়ে আছেন, unmute করেন, mute হয়ে আছেন.
এখন শোনা যাচ্ছে? Can you hear me? Jonaki, can you hear me?
শোনা যাচ্ছে, শোনা যাচ্ছে.
Okay.
We can hear you.
At the beginning, I want to express my gratitude to Dr. Jannatul Firdaus, who have given me the opportunity to participate in this international webinar. The question you asked me is as suggested by different guidelines. In COVID pandemic, the high priority patient should undergo surgery. And we know that the patients who belong to the high priority are the patients whose life is threatening. So among this group, there are patients who are coming with complications like a malignant ovarian tumor with torsion, or a patient coming with intestinal obstruction, or any patient who is coming with post-operative complications like anastomotic leakage. These patients are considered as high priority group, and all the guidelines have suggested that these patients must be operated even if the situation is pandemic for COVID. But the guideline also has suggested that there are certain patients which we very frequently come across are the patients like patients who are in the early stage ovarian cancer, and they have suggested that the surgery should be deferred. Some guidelines say it should be deferred for 6 to 8 weeks. Some guidelines say that it should be deferred for 4 to 12 weeks. The second group of patients are considered as semi-urgent. These patients are patients who are in the advanced stage ovarian cancer and who has been scheduled for primary cytoreductive surgery. These patients, they have considered this patient as semi-urgent, and they have proposed that these patients should, instead of being undergoing surgery, they should be referred for neoadjuvant chemotherapy. The third group of patients are the advanced stage ovarian cancer who are already in neoadjuvant chemotherapy, and the proposal is that to continue the neoadjuvant chemotherapy for 3 more cycles and continue the treatment up to 6 cycles. Now, this was the guideline which we started at the onset of COVID pandemic. Now, already we are nearing about 12 weeks completion of the pandemic, and the pandemic is still continuing. So how long we have to continue the pandemic, we don't know. So these patients, the second group of patients, which I told you, have already completed 6 to 8 weeks, 4 to 12 weeks. And the neoadjuvant chemotherapy group have already completed their 6 cycles. They are now coming to us. So these patients need operation now. So whether the pandemic persist or not persist, we should start operating the patient. But according to the guideline, definitely, obviously, the laparoscopic surgery should be abundant in favor of open laparotomy.
Okay, then, Madam, what essential measures do you need to take during performing this kind of surgery?
Well, this is again according to the guidelines, that if we divide the patients in the 3 groups, that is how we will deal the patients before surgery, how are we going to deal the patient during intubations, and dealing with the patient at the time of surgery. So if we start with one that is before surgery, we need to thoroughly counsel the patient and the family members about the need of postoperative ICU, and also the need of transmission of COVID-19 if she is operated. And as such, an informed consent must be completed. The second important thing before surgery is, which many of the hospitals practices, is to patients should be subjected to COVID tests. And many of the hospitals are now practicing that COVID test is a mandatory before surgery to perform an operation. Though the Ministry of Health has not recommended that it should be a mandatory task. So, but hospital is now preferring the patient must have a COVID test in hand before she is subjected to surgery. Now, the precautions what we are taking at the time of intubation is that since these are the aerosol generating procedure, there is high risk of transmission. So during this aerosol generating procedure, anesthetic and his team must be fully prepared with effect PPE that includes cap, goggles, face shield, double masking, wearing PPE, foot cover, and everything. Another important thing is the use of pressure powder air purifying respirator. This helps the anesthetist to get himself safe from the transmission. And in most of the hospitals, this EARP is not available in Bangladesh. So many of the patients are given intubation with EARP. During intubation, the surgeon and his team should not be present in the operation theater. It is only the anesthetist and his assistant who should be present in the OT. Next comes, well, how we'll be dealing with the patient during operation. During operation, the operation must be performed in a negative pressure OT. Now, a negative pressure OT is such a OT where there is less risk of transmission of infection because of the pressure, the microorganism from outside cannot come inside. Side by side, if the COVID positive, the viruses which is sucked out by the negative pressure. The second important thing during is that the surgeon and team or her team must be fully on PPE. And the third important thing is that no extra personnel should be entered into the OT. And last of all, if 2 operations are done, there must be a gap of 1 hour in between the 2 OTs.
Okay, thank you so much, madam. Dear audience, we are at the end of the gynae-oncology session. And please, we can give a clap for the panel of gynae-oncology session. And now I'd like to move to the obstetric session, and I request Dr. Ashfaq to conduct the session. But I have a small correction. In obstetric session, we have one of the panel from UK, and her name is Nadia, Dr. Nadia Islam, rather than Dr. Nadia Sharmin. Dr. Nadia Islam. Okay, Dr. Ashfaq, please continue.
Thank you, Professor Firdaus. And so we concluded the gynae-oncology session. I write down some take-home messages, which I will pass on at the end of the session. So we now move on to the obstetric part. And as you know, that we have got 4 panel members from UK and 4 panel members from Bangladesh. And I first request Professor Samina Chowdhury to give us a welcome address to all the panel for this session. Professor Chowdhury. Can we request Professor Samina Chowdhury, please?
Dr. Ashfaq, Madam has just informed me that she has electricity problem at her home. So can we start the discussion, question answer session directly?
That's fine. That's perfect. Okay, we'll do that, and we can always hear from.
Question answer chilo, question comment chilo.
Yes, Madam, we will do that. If you can kindly hang on with us a little bit more, because we are a little under pressure from the time constraint we have got. So let us finish this session. We'll take the question at the end, if you don't mind, please. So let's start the session for the obstetric. Now, my first guest from the UK is Benjamin Black. I always used to believe if I had another life, I would like to be Benjamin. I always used to tell him. This guy has traveled all over the world. Amazingly, I saw him as a registrar, but I hardly see him in England. He's most of the time traveling. He worked in Sierra Leone as a Doctors Without Borders with Ebola. And I remember that when I used to hear his stories, shocking stories, his experience with almost leading an obstetric center with emergency situation in Ebola. And I'm glad that during COVID, he's in England, and we had his expertise there. And what another important thing is he's very well connected with Rohingya refugee management team, and very often we get update from him about Bangladesh. So welcome, Benjamin. Thank you for coming. Now, just to start off, from the point of emergency management of the obstetric care, did you notice any sort of difference between managing the obstetric in Ebola situation and in COVID, in short?
Right, thank you very much for the introduction, and greetings to everybody today. I'm also joined by my colleague, Pippa Letchworth, who's an obstetric and gynecology consultant at Mary's Hospital in London, and has also been assisting on the COVID-19 response in maternity and in gynecology here. So for your first question, looking at my experiences during the Ebola outbreak and how we managed obstetric care then, I think that there's certainly a lot of similarities between the COVID outbreak and the Ebola outbreak. Certainly in the indirect consequences of the outbreak, you can see a lot of parallels in the way that we've seen that the epidemic was growing quite slowly. We could see that it was coming. We could see that there were changes that needed to be made, but that quite often those changes were coming behind the curve. And this was certainly paralleled both with the way that Ebola happened, that we knew that we were walking into an epidemic, and the way that COVID-19 has happened. Similarly, what we've seen from the maternal health side is that many, many more pregnant women will come from harm and will die during this time period from pregnancy-related causes, rather than from causes directly of COVID-19. And this was exactly the same during the Ebola epidemic. And we know that the disruption to healthcare services, the inability to access, the fear of the health services, the loss of healthcare workers, all of these things will have very significant indirect consequences on the morbidity and mortality of pregnant women. Equally, we know that disruption to aligned services such as contraceptive services, services targeting gender-based violence, STIs, HIV, safe abortion care, all of these will have knock-on effects as well for our maternal outcomes because of disruptions that we see with COVID-19. I think the other similarity that we see, of course, is that infection prevention and control has become, although we have always talked about it being an important aspect of our work, it's now become very, very central to everything that we do within our patient care, within our patient interactions, and it's a thing which has taken a center stage much more than previously. And this can have both a positive impact on the care we provide, but also a negative impact in the sense that we can sometimes slip into a slight tunnel vision where we become overly focused on what we need to be doing for COVID-19 at the expense of being able to maintain our safe and accessible maternal health services. So I think these are probably the biggest similarities that I've seen. But I would also stress that there are some big differences as well. Certainly, Ebola and COVID-19, whilst we can draw some parallels, they're very different diseases, very different routes of transmission, and for pregnant women in particular, very different mortality rates for the direct consequences. And I think that that's very important to keep in mind, that we know that the vast majority of pregnant women that get COVID-19 will remain healthy and well during that time period, and that their greatest concern will continue to be maternal sexual reproductive health reasons for being in health accessibility. Secondly, we know that Ebola was something which was transmitted through bodily fluid exposure, whereas for COVID-19, the route of transmission is different. That our way that we work, particularly in a specialty where we have a lot of exposure to bodily fluid, is different because our focus is much more around restricted transmission and making sure that we're protected around our mouth, nose. I'm
going to move to the next question from here. From your experience of, and both of you can answer that. Pip, how are you? Sorry, I didn't introduce you, but thanks for being there. So the experience of doing an emergency cesarean section, what are the things that you found very challenging, and how did you change your practice in the last 2 months when you were dealing with the peak of the pandemic? Any one of you can answer that. Pip, you can try.
Well, I think the fundamentally doing an emergency cesarean section in COVID and out of COVID, the vast majority of it is actually very similar to your normal day job. Obviously, the fundamentals that we implemented in our unit was to try and mitigate against the general anaesthetic cesarean section. So if you are in an institution where you can have regional anaesthesia and someone looks like they may need it, then we get that in earlier rather than later. And essentially, just trying to avoid general anaesthetic is the mainstay of our intervention. But otherwise, doing an emergency section in the time of COVID is actually, pretty similar to not COVID. It's just
PPE a problem when we were operating with the full PPE. Was that a challenge?
Well, so we weren't operating in full PPE unless they were under general anaesthetic. So we probably at our kind of central London hospital have done a handful of general anaesthetic cesarean sections throughout the whole pandemic, and then in those situations we were in full PPE. But full PPE is not that obstructive, in my opinion. Anyway, for doing a cesarean section, it's a mask, eye protection. But really, the mainstay is to avoid your general anaesthetic and then have very simple measures. So the most important thing probably is the mask on the patient that's COVID positive. These things are very simple. And then, avoid a general anaesthetic and then do your routine cesarean as you would do.
I think
from Benjamin, from the decision-making point, did you find that, because anesthetist, when you say that I want to do a trial in the theater and it may end up with a cesarean section or so, did you find that communication with the anesthetist was an issue with that? And also, did you do something different to avoid that last minute emergency in the theater?
So I think that I'm going to take all of it, all this question and the previous question together. So I think that the main principle is that the majority of the care does not change. So the decisions that we make don't change. The important thing is making sure that those decisions are made by someone relatively senior in a timely manner, because this is what reduces the anxiety levels. And a lot of it is about management of anxiety and management of the team not getting worked up, that they feel panicked. If you've got someone more senior that is able to say early on, this is what is happening, this is what we're going to do, and go, then people tend to work in a much more calmer manner. The main issue really is it's an infection prevention control issue. You know, this is an infectious disease outbreak, and for us, the main issue is about making sure that we've got safe infection control behavior. And so for the operating theatre, that means making sure that we clean the operating theatre appropriately after every case, allowing enough time that it's disinfected properly. But secondly, it's also for COVID-19, recognizing that, you know, we don't know which of our patients, particularly in maternity, have or do not have COVID-19. Because don't forget, we're very different to the rest of the hospital. We're not a department that is filled with sick patients. We have a community group of patients who are there because they're generally well and giving birth. And across the community, you're going to have very different presentations of COVID-19. And so we know that up to 50% of people with COVID-19 will either be pre-symptomatic, low symptomatic, or asymptomatic. And so you may have, with all the best questionnaires in the world, you will still have potentially, if you've got high transmission, up to 30% of your women passing through your department with COVID-19 and not knowing it. And so the precautions that you take, I would argue, should be the same for all women, regardless. And actually, this just makes life much easier on your labour ward and much easier with managing emergencies and managing the operating theatre. Because then everyone just does the same thing for every patient, and it becomes very routine, a very matter of fact. And a lot of the excitement and panic gets removed because there's nothing special. Every patient's treated the same, everything is cleaned the same, and you carry on, because the infection risk isn't going to change.
Okay, excellent. My last question, but that's probably important. I know you're very well connected with the Rohingya refugee camp in Bangladesh, and you probably had a webinar very often. What's the update about the Rohingya situation with obstetric care wise? I mean, in a nutshell, because we have got so many high-profile professors here, and they're connected with the government level. So maybe some genuine, honest opinion.
So the Rohingya situation, as I'm sure many of you know very well, is incredibly complex on political, social, economic, as well as health reasons. And so we have a real mixing pot here. I think with COVID-19 and maternal health care, one of the big problems we're facing is the access to emergency obstetric care. We know that within the Rohingya camps, there's been a move towards building the CITCs, which you may have come across, of these COVID isolation and treatment centers, to try and remove the infected Rohingya out of the camps. Within that, there's also been some emphasis towards having women in labor who have COVID-19 symptoms also moved into these isolation facilities, which means they're not giving birth and not being cared for in facilities which are used to looking after pregnant women. And given that we know that about 15% of pregnant women will have some sort of obstetric emergency, and that they're largely unpredictable at knowing which of these women they can be, we're putting a high level of risk of moving these women into a facility where they don't have easy access to emergency obstetric care. And if they need that obstetric care, they're not being received by the other hospitals, not very easily. So there's a lot of
that's probably,
barriers.
Yeah, okay.
Yeah.
Thank you so much for your contribution. We all appreciate your contribution today and to give up your Saturday afternoon for us. I would just request Professor Samina Chaudhry, who just joined us, to give her address to the panel.
Hello. Hello. Can you hear
We
me?
can hear you. Yes, we can all hear you.
What is your question, please?
So
Hello?
because we missed you earlier, we thought that you were supposed to give us the welcome address.
Okay, because
if you
there
want
was
to.
a transformer bursting, and that's why there is a problem in internet connection. And I must congratulate all of you in this webinar session of East and West. And it's very interesting that we are having enough experience from them, and we are exchanging our experience. And about the emergency situation in COVID situation, how we can do the section, or is there any how we can protect ourselves? That is one important issue. For that, I can say that all pregnant women should have testing for COVID in the OPD, whether she is with symptom or asymptomatic. And after triaging, we have to select the patient, and we have to prepare the patient that she have to wear the mask, mainly the surgical mask during the operation. And in the operation theater, all personnel involved in the OT, they should wear the novel respiratory isolation PPE, especially N95 mask, gown, gloves, double gloves, and it is better if it is long sleeve and protective eyewear, and also the surgical hat. These are things to be all the surgeon will wear. And another important issue is that the personnel who are involving in the OT for the transporting the patient, they should also wear the mask, but they can use the surgical mask, but other protective measures they will take. About the OT, it is better to keep the OT at the end of the all the OT. When it is completed, then we will keep it at the end, so that we can get enough time for reusing it and fumigate it or cleaning it. And if there is any another emergency, we can do it after half an hour after proper cleaning. We have to give half an hour space for that. And so I think another important issue is that about the donning and doffing, and they should be attached with the nearby the OT. These are few things we have to think of and rearrange the OT, and also the whole OT complex. We have to rearrange for COVID patients, how we will make it infection control. We have to think in our OT what we are doing. Still, I think that it is not enough. We need to rethink it, and we have to make it COVID-19 friendly. Otherwise, our doctors are getting infected day by day, and it's going to a very miserable condition in Bangladesh now. So I think we have to give more emphasis on that issue.
Thank you, madam. Madam, we're going to come back to you again. Is that okay that we come back to you with the panel question later on?
Okay.
Because we missed you initially, so we couldn't really explain the session to you. So we are now completing the...
Sorry, I missed it.
Yeah, I know, madam, but if you stay with us, I'm definitely we are going to explain to you a little bit more. We're just trying to finish the UK side, and I was waiting for you for your welcome address. But
Okay,
you covered
okay.
so many important things already. That would be helpful for my next guest. Is that okay, madam, if I carry on? Okay. Now, can Nadia unmute, please?
Yes, can you hear me?
Okay, yes. So Nadia, as you can hear that, the reason I invited you because you were working as a junior registrar during COVID time, going through the full rota and doing season section, labor ward and everything. Now, I know that there was a bit of discrepancy what is PPE in England and what was safe. I know that we didn't have full PPE when we did season section or so. So my first question is that, can you kindly briefly describe me what was your on-call rota was like during the COVID? Just pick up a week or 2 weeks.
Okay. All right. Okay. So when I'd like to thank Mr. Khan for inviting me to the session, and I'd like to say good afternoon to all my senior professor and doctors in the session today. So the question regarding our rota as a registrar on the labor ward or gynecology, we previously used to work in a 1:16 rota, including all the GP trainees and the foundation year doctors and all the ST2 or ST3s. But when the COVID-19 period,
you're working 1 every 16 day on call.
Yeah.
Yes.
And then when the COVID-19 period started, so all our GP trainees and the foundation year doctors were redeployed to a different medical department. So from 16, we became to 7 in total. So we used to work in night shift or long days or a normal working day from 8 till 5. But when this redeployment happened, so when the reduction of doctors happened, we had to work like only on call, like 8 till 8, either it's a long day or only night shift. And we used to get labor ward block as a registrar or like elective cesarean section block for 3-4 weeks in a row. And that's been stopped because we had to minimize the number of time spending inside the theater. So we are trying to do the cesarean section by only the consultants or the senior registrars who are actually really competent, and they can like minimize the time of theater spending. And that's all like created a bit of problem because, and we also came up an idea, like we had to put someone on a cover shift, like on a long day or weekend on call or a night shift, because if there was an increased number of isolation and sickness from the staffs was happening. So if someone calls off sick suddenly at like 10 o'clock in the morning or 5 o'clock in the evening, so there was someone has to be on the cover shift on standby, like a non-resident on call.
Backup on call. So
yes,
that
yeah.
person will be called.
So
okay.
Instead of calling someone locoming for that shift, so she or he can be called on a short period of time, okay. Like knowing she'll be always be on call,
right.
non-resident.
So, how many times have you been tested for COVID?
So whenever we were symptomatic, so I have been symptomatic twice. So I have been tested twice for COVID-19. So when we become symptomatic, we have to let our occupational department know, and we actually get a test within 24 hours of reporting the symptoms to them. And we generally get the results back within 12 to 13 hours, actually. That was really good.
And as long
positive? No. None of them.
Interesting. So you felt symptomatic. You were
I was quite symptomatic, so but then the results came back.
That's an interesting thing, that not all fever and cough would be a COVID. Now, what about your friends in a group of 7 to 10 people? How many of you actually falls as COVID positive and was sick and out of job?
So my friends were mostly isolating because either their partner or husband or like any of the family members were like symptomatic. That's why they were in isolation for 14 days. However, if they were symptomatic, they get a test and the test come back as negative. They generally come back as soon as possible when they're feeling all right or feeling well. However, there was a time when the hospital did a random selection of asymptomatic patient testing, and 3 of my colleagues came back as positive without any symptoms actually, and they were sent for isolation. But I don't think anyone ended up in a very serious infection or end up in IT or anything.
Excellent. My last question to you, because that is relevant for my next segment. Was it important to have a senior person in the labor ward?
Yes.
Did you find it change anything, like a feeling a consultant or upper senior registrar level person?
Okay, all right. Because I work in a tertiary unit, so we work in a two-tier rota. We mostly have a consultant on call on a labor ward most of the time, apart from only was Thursday, Friday, and Saturday night. But when this COVID period started, we were having 24/7 consultant labor ward cover all the time. I think it was mostly because we wanted to reduce the time incidence of calling a category 1 cesarean section, because according to the NICE, it has to be done within 30 minutes of calling the cesarean section. And because of this donning and doffing issue and the anesthetist and the ODP preparing the patient, whether the patient has a chance of going under GA, so so reduce the chances of having a calling a Cat 1 cesarean section. I think presence of a labor ward consultant is really important, so we can have a low threshold of cesarean section.
Did you use double gloves for surgery?
Yes, we did.
Did you use the face shield, or did you wear the full PPE?
So
just
for
in brief, what you wore?
In case of GA, we use the FFP3 mask, visor and double gloves and full PPE. However, in case of epidural all spinal cesarean section, we use the surgical mask, the visor and the gloves, double gloves and the gown, but not FFP3.
Excellent. Thank you so much, Nadia. Thanks for your contribution. Now I move on to Ms. Rehana Yasmin, and she's a consultant obstetrician gynecologist in Isle of Man, beautiful place. And welcome, Rehana. And she's also the chair of the RCOG Bangladesh Liaison Group. Ms. Yasmin, my first question is that how do you support the junior doctors who are extremely anxious and worried, but they are being the front runner for everything? And how did you provide the support to them?
What I take from Nadia is that she already mentioned that what we did, the seniors are actually visible all the time. So they had almost 24 hours presence of consultant in the hospital. So that's why whenever they needed any assistance, they didn't have to actually call us from home. We are almost here as a resident consultant. And as also Nadia said, from the 3-tier rota, we actually did 2-tier rota because most of our junior trainees were actually taking to another wards for help. But so then there was only registrars and consultants. In our department, so occupational health did a risk assessment for all the staffs. So, and then they categorize into, like, say, who is in the high risk and who is in the moderate risk, who is in the low risk. So out of our 5 consultants, 1 consultant was not able to work direct contact with the patients. So then we had only other 4 consultants. So we paired up, and one week we almost did 24-hour on calls every other day among ourselves, among these 2. And then other week we present in the hospital, but we were doing admit work. But we were still in the background. If anyone gets sick, then we will be stepping in.
Your off day is not really an off day at home.
No, it was.
And I think the other interesting thing was all the gynecologists in many hospitals was asked to do the elective cesarean section, so that the obstetricians can give 100% to the labor ward, and they're not pulled away for anywhere. And I remember that most of our gynecology colleagues were doing the elective section. Again, even though there was senior registrar available, just to reduce the complication and reduce the timing of the surgery. This was all performed by the senior people.
Exactly, Skal. Actually, that also gave lots of moral support to the juniors, because to make decision, to reduce the complication rate and the exposure to the patient from both sides. So the patient hospital stay was cutting short, as well as we as a obstetrician or the doctors or the health of the providers were reducing the time of contact with the patient. But the scenario is a little bit different than Bangladesh and us, is that in Isle of Man, especially, we'd had a very successful lockdown and very successful, distance maintaining and everything. So patients were actually, most of them are at home they were not going out that much, and they had maintained the distance, so they didn't have contact with others. That way we were lucky. But when we hear from my colleagues from Bangladesh, it's not possible. And being a Bangladeshi, like born in Bangladesh and study there, I know it's impossible to have a successful lockdown in Bangladesh. But why? What I think, if I was in Bangladesh, or I will suggest to all my colleagues, seniors and juniors, that they just have to take everyone as they can be coming in contact, can be at risk of transmit the infection to them or them. So they have to take all the precautions themselves. They can't actually educate the whole population to be locked down and maintain whatever needed to risk of infection. So as if healthcare providers, doctors, nurses, midwives, they all need to take their own precaution, because the way I look at, I came to know from the social media and others that so many doctors are dying, and which is not actually acceptable. That's quite demoralizing from all rest of the colleagues. And if you look at the Imperial College model, when they put it on the Bangladesh scenario, Bangladesh hasn't actually reached the peak yet. And some of the suggestion is that the peak may reach in September. So there's a long way to go. And it's not like going to be a sprint, it's a marathon. So everyone has to, to provide emergency safe service. The first thing everyone needs to do, whether it's a small hospital or a tertiary center, risk assessment of all the staffs, and then categorize them into like who is in mild risk, moderate risk, and serious risk. That's the way you can manage a successful service. Otherwise, there'll be lots of
suggesting that as we had, every staff, especially will have a risk assessment, personal risk assessment. So if that doctor is a high risk group, they should not be deployed to do labor ward or red zone work.
Exactly.
Even I know a lot of gynecologists and a lot of obstetricians who were very busy. With the COVID time, they were asked to work from home, and those who were in low risk were allowed to work the on-call rota. But it depends on the personalized risk assessment. I know there's a tool. Probably you can send it to us later on, maybe. That can be helpful.
Yeah, so it's basically what I'll do, it's quite interesting. So I think it will be very useful. I don't know whether you can implement in your setting. We are lucky that we in NHS, we have got a very structured healthcare system. But even then, initially, either because of the political reason or something, we didn't do well. That's why we still lost 41,000 people, which is like a big stadium full of people has died. But I think there's lots of learning to be taken from here. Now, 40% of the doctors and 20% of the nurses in NHS are from actually Black, Asian, and minor ethnic groups. And most of the colleagues we have lost, whether it's a doctor or nurses, they actually came from these groups. Now, looking at the age, ethnicity, sex, and everything, as well as whether they got existing comorbidities, that risk assessment has been done. And as Ashfaq says, many of the colleagues who are in high risk group, they were not coming in patient contact, but they were mostly participating in the telephone consultation to running the virtual clinics. And so that's how we managed.
Thank you so much.
Dr. Ashfaq, I'm very sorry for interruption. Actually, Professor Roshanara Madam has another webinar, and she has to leave.
Yes.
So can I ask?
Yes. I hand it over to you,
Madam.
Then we can do that.
Madam, can you hear?
Yes, I can hear you.
Okay. Madam, we know that the government of Bangladesh has formed a national technical advisory committee to tackle the outbreak of corona in Bangladesh. And you are one of the leading member of this committee. You are always raising your voice for us. And the committee has formulated a guideline, but in that guideline, the gynecological oncology management protocol is not incorporated. So is it possible to incorporate in the next updated guideline, as we are observing that non-communicable disease, cancer cases are increasing in Bangladesh?
Thank you, Dr. Jannat, and thank you, Dr. Ashfaq, for a wonderful panel discussion from the East and West. I'm very much enlightened with this program. And so I'm sorry for the interruption. Actually, National Advisory Technical Committee is working for 1.5 months, and they have made 6 subgroups. One of the important groups Hospital Management Committee, and today they are finalizing the main guideline. I also communicate the things that I have sent with the question to the committee. I think they will put it, but I know the general oncology surgeons, they have made their one guideline. I think you can make a guideline and I can send to us also in our committee, so we can incorporate in our, I can send our hospital committee, they can incorporate with this committee. They are a wonderful SOP. I have gone through the SOP. It's a wonderful SOP. I think I can put your proposal if you give me a proposal from your oncology committee. Thank you.
Thank you, madam. Thank you, Dr. Ashfaq, for letting me take your time. Please continue.
That's absolutely fine. And to Professor Roshan Begum, I think during the COVID time, there's only two service works: oncology and obstetrics. So please include oncology. Don't ignore it. Our request from here.
No, of course.
Thank you so much. Our last guest in the panel from the UK is Ms. Parveen Akhtar. She's a consultant obstetrician, but also lead for the high-risk pregnancy and fetal medicine in the Queen Elizabeth Hospital of Norwich. And I'm going to invite now Mrs. Akhtar. Can you please unmute yourself?
Just unmute yourself, please.
I think.
Dr. Akhtar, please unmute yourself.
She can hear.
Okay. No, she can hear, but we can't hear her.
She's trying.
There is a button in the corner of your computer.
Yeah.
Can you hear me? Thank you. Yeah, thank you.
All right. Now, my first question to you. What's the situation of testing COVID for antenatal patients as a empirically, just without symptom? What is the current situation is that in the UK, and what's the evidence?
Okay, thank you, Ashfaq, for inviting me. I need to say something because this is the platform I am sharing with a lot of legends from Bangladesh, and this is where I am. Some of them has brought my hand, took my hand and brought me here. So where is Roshanara madam? She probably has left at this stage. Thank you for giving me the opportunity. So this is the question, perhaps we were talking at the end of the discussion, but however, I think testing COVID in the context of pregnancy is quite a controversial and quite a debatable issues currently around the globes, because A, the authenticity of the testing, the B, how many tests we should do and which test we should do, because there are two main types of tests. One is the antigen test, which is the culture we can find out whether the woman has a COVID at the same time when they're presenting. The second one is whether there is an immunity there or not, which is the antibody test, and which probably is going around the globe as the quick fix test. So in COVID situation and the pregnancy context, there is no as such routine testing which we should offer for an asymptomatic pregnant patient. We just need to go case by case. At the moment, the Royal College of Obstetricians and Gynecologists, in parallel with the Department of Health, has drawn up some form of recommendations which allows any woman who comes to the hospital, and if they require admissions overnight, they should be offered a test, which is the antigen test, which is the swab test. If they remain inpatient and stay more than 5 to 7 days, then they would be offered another test, provided the first test was negative in the first place. If they become symptomatic in the meanwhile, then they get another test and they will be treated accordingly. Any pregnant patient, they will be considered as like a general public. So any general public can have the antibody test through the Department of Health and they can volunteer and they can go and book that test. There is no limit to that one, and they can do whenever they wish to do that one. In terms of the elective surgery, we have been speaking, or elective admissions for induction of labor, or the elective cesarean sections. We were asking the women to self-isolate for a few days or a week. Now that has been extended to 2 weeks. And before the date of their procedure, 2 to 3 days prior, they should go for their swab test. And then if the swab test is negative, then they automatically come for the procedure.
So that is also for the induction of labor?
That's also for the induction of labor. If the swab test comes positive, as you know that UK has a very integrated obstetric system, then they will call into their midwives, and then that will be brought to the attention to the obstetric group, and we review the situation, and we will then balance the situation between the fetal risk or continue with the procedure, or if we do it, take the all precautions for the COVID.
Sorry.
But this may not be the same situation. Yeah, there is another group of people who in the other part of the Europe, they are practicing a bit differently. They do offer the antibody test to the pregnant women when they come in, whether as an inpatient or outpatient settings. They do offer them the antibody quick test. The problem with that quick test is we don't know what is it mean for. If it is positive, is the patient is carrying the virus that time, or has it got the full immunity or not? But however, they're practicing in such a way, it is their own safety that they do the test, and if the test, both immunoglobulin M and G is there, they kind of take at a positive and they offer the swab test, and they send the patient home until the test result is available. If it is negative, then they treat as a COVID negative. If it is positive, then they follow on from there. So the rationale of doing that one, it also depends on how much resources you have. So in the context of Bangladesh, how much that will work, that is a debatable situation. I have overheard, and I have actually listened to some of the panel group from India, where the legends as well, and their government from there is trying to implement this system. But I don't think so that actually the practitioner obstetricians, they are finding it at all useful. So I think it will depend on the healthcare system you're working. What is your national strategy, and take it from there.
I think to some extent is also a bit of political thing, because you're giving a hope
Absolutely
to the people that we are doing your test, but you're doing an antibody test, and being a positive for antibody. I don't know what it means.
What it means, and states started as, is it a passport for your immunity or not? But it is not like that, because how long what COVID do you have, or how long the immunity lasts, or is it a full cover at all or not? So
okay, I move on to the next question, Mrs. Akhtar, is that how safe is to run a high-risk pregnancy clinic by video and telephone? So we have now moving more to the telephone clinic, and I'm thinking it's happening in Bangladesh also. What are the prerequisites, and how you feel as a lead for high-risk pregnancy to run a clinic like that?
Okay, thank you for asking that question, because I have been running and established that service in our unit. I think this kind of virtual clinic concept was there for many, many years, but the COVID has made it a reality. But it is not as simple as we think. It requires a lot of infrastructure, a lot of communication, integration. It is possible in the context of UK, where that full obstetric system is so much integrated, and we have so much multidisciplinary group attached to us. In order to say the high risk, there are a couple of segments to your question. One is your high risk, one is the monitoring, both fetal, maternal, and the safety of it. So if we are talking about the high risk, the way the UK and the National Health Service works, the model of care, any patient, when they're pregnant, they go through the primary care setting where the midwife decides which groups these patients belong to. When they're low risk, they don't come to the hospital. They're done and dusted by the community level, by the GP and the midwife. The high risk group, again, there are 3 groups in it. One group is the risk because of the maternal risk factors, because they have some medical conditions attached to them, which could be anything very significant, cardiac conditions, or maybe mild neurological conditions like a migraine or something like that. So these group of patients, they are in the first instance assessed with the risk strategies and reviewed by the obstetricians, and the managements are put in place. So they can easily qualify for these virtual clinics because we work through the different midwives. There is a named midwife which works for this particular patient. And also there is the specialist nurses or midwife which works as well. So these virtual clinic, although you're doing a telephone consultation for just instantly, but there's a lot of work goes before this telephone consultation or the audiovisual consultation and after the patient has left you. There's a good triaging system works so that we can identify the right patients who can qualify for this consultation. And the results, even I'm doing remotely from my home, these clinics, but I have the setup in my hospital laptop that all the results I can access, including the ultrasound, all the charts I can access, and I get at least 40 to 60 emails from the different multidisciplinary groups, and I go through them and I can accordingly manage the patients. And there is an integrated digital system in the laptop where whatever management I provide, wherever the patients are, the midwife, the other specialties, other consultants can see that one and they can carry forward. It works for the patients who doesn't need the examinations, but if the patient needs an examinations where they need an ultrasounds and physical examinations, but in the context of Bangladesh, because there are significant number of the patients carry the small babies. So the measuring the symphysiofundal height is very important, and tailoring that into the ultrasound context is very important. Those patients cannot be consulted over the telephone. However, we can bring the concept of the one-stop clinic for them so that we can reduce the number of their visits to the clinics. For example, we can have the examination, we can have the ultrasound, we can have all the blood tests done in the same setting so that the patient doesn't have to travel a few times a month or weeks to the hospital. So that does work.
So there needs to be a lot of work at the background and reliable way of monitoring them at home or the community.
Absolutely. And the third thing is, the easy thing what we can perhaps work in Bangladesh is a lot of the patients in the private sectors, they are quite intelligent. They have access to the blood pressure machines. So if they are PET or PIH, you can ask them to measure the blood pressure at home. And then if you have an integrated email system, they can email you or your hospital service managers. We can put it into the place.
Thank
so
you
it
so
works.
Much.
Yeah.
Yeah. I'm just interrupting you. I'm very sorry.
You're out of time. I can understand.
Yeah, but thank you so much for your contribution. I think we all learned a lot from you. And just to sum up these sessions from the UK, and I just want to highlight one thing before I hand it over to Professor Firdaus, is that, again, we are very grateful that you gave your time to listen to us. It was mainly to exchange our views. By no means was trying to educate or teach you. We are extremely grateful that you are there. That's why our parents, our sisters, our aunties are there, and we feel safe. So thank you so much. And we want to also thank all the junior doctors. I don't know whether they're listening. You're doing a great job, because I know, being a consultant, how much I depend on the junior doctors, and really they help us. So thank you so much for working so hard. And only one thing I will request all my senior colleagues: every day, make it a habit in the morning, first thing you do, thank the juniors. Bring them in the room, just give them a big thank. Buy them coffee, buy them anything. It makes such a big difference. And it gives them a boost up for the whole day. And I think without them, the healthcare system will not run. And I will just re-emphasize the same thing. We cannot save everyone, but we can at least try to be a bit more organized. NHS, as in England, we didn't do great. A lot of people died. We know we criticized, but in the hospital, actually, we did not cross a lot. Our death rate in the hospital was less, and we did not allow NHS hospitals system to collapse like the way it collapsed in Spain, Italy, or even New York. So that was the only good thing we take home, that with the organized system, I really hope that we achieve it from today's webinar from the UK panel. Over to Professor Firdaus. Thank you.
Sorry, Ashfaq, can I add on one thing? Because we are talking about obstetric safety. In the context of Bangladesh, I would really urge, when the pregnant woman comes, and particularly in labor, please look into the anticoagulant, because that can save a lot of the life. Not because of the DVTs, but in the COVID settings, where one of the major issues are the ARDS and this coagulation, procoagulant stage. So please look into the anticoagulants and start any form of anticoagulants as early as possible, rather than leave it too late. Thank you.
Thank you so much. Again, the virtual water lily for token of appreciation, and a big clap for our panel. Now I like to move on to Professor Samina, Madam. Actually, Madam, you have already answered the question I had for you while answering Dr. Ashfaq's question. But one important question to you is that in some center, some are suggesting CT scan in the suspected pregnant woman, suspected COVID woman. What is a suggestion? Yeah, what is the role of chest CT in suspected COVID pregnant patient? What is your opinion, Madam?
Actually, American College of Radiation, they have said that only one single X-ray that we are doing, the radiation is not that much for causing any harm to the baby or mother. But in general, the CT scan is not recommended in pregnancy unless the benefits clearly outweigh the potential risk. And what happened? It has been found that if we do CT scan in early pregnancy, it is carcinogenesis and from the radiation and also teratogenesis. So we should not do this, especially in the first trimester. Another thing is that during this COVID situation, Wuhan has undergone some CT scan in pregnant women, but they have done it by giving very low dose technique they used, and it was implemented with the dose length product, ranging from 50 to 150 milligray for the diagnostic imaging. In the study, they have shown that it is quite safe, but still we need to think whether we will do it or not. If it is really needed for life-saving decision, then we have to consult with the other disciplinaries that whether we need it or not, or we have to go on other way to diagnose it. So I think it's better not to do CT scan in pregnancy. Is it? Okay. Hello?
Okay.
Whether you hear me?
Yeah.
Because I cannot see anything because there is no current, there is a transformer already busted it. So
okay, we can hear you clearly. We can hear.
Okay.
Thank you so much. At this moment, I like to ask Professor Saleha Begum Chaudhry. Madam, in OGSB, you were involved with all key functions as Secretary General. We know that hundreds of doctors got infected during working at hospital. You are also a frontline fighter and became infected while dealing with a suspected, with a complicated case. So my question for you, if anybody become infected with COVID, when he or she can return to work, and what extra precaution he or she should take? Madam, please.
Can you hear me?
Yes, madam, we can
Can
hear
you hear
you.
me? Oh, actually, I can't hear you because there is a disturb in the
internet connection.
I think internet connection.
Madam, should
So
I
please
repeat the question? Repeat the question.
Yeah.
Okay, madam, I said that you were a frontline fighter and became infected while dealing with a complicated case. And my question is, if anyone, if any healthcare provider become infected with COVID-19, when he or she return to work, and when he or she return to
actually,
work,
yes.
Madam, can you hear me? Madam? Hello, madam, can you hear me?
Can you hear me?
Yes, madam, we can hear you.
Yeah.
We can hear, madam.
Yeah. Okay. So really infected, and you know the guidelines are actually adopted on the patient needs as well as resource available, and as well as emergency. To take precautions. So and there are the guideline for symptomatic healthcare provider. They should follow that is symptom based. First point is, first criteria, that is resolution of fever at least for 72 hours without taking any medicine for reduction of temperature or for reducing cough and shortness of breath. And also include that 10 days have passed since the first symptom appeared. So all turn to work. And there is also another strategy, that is test-based strategy. That is at least sample, respiratory sample collected at least 24 hours apart and comes as a negative to strategy. That means that 10 days have passed since the first exposure. But and he or she must be remain symptomless. But if symptoms appears, in that case, she or he has to follow the symptom-based strategy. That is resolution of fever for at least using fever reducing medication and improvement of respiratory symptoms, and as the symptoms appears. That is the first one. That is for asymptomatic patient, not symptom, but who have symptoms. If the healthcare provider develops symptoms, in that case, she have to follow this symptom. This consecutive sample, respiratory sample collected in 24 hours and comes negative by RNA test. And But one thing is important: if asymptomatic healthcare provider develops symptom, she will follow this, and she also monitor himself or herself for whether there is any symptom or not, and she has to follow in that way, and also she symptoms appears or appear, she has to evaluate himself or herself. But another important point is that is shedding of virus may be continued even after 10 days, but it does not necessarily mean that virus is infectious virus is present. And RNA test also comes as a positive even after 10 days. In that case, that is also necessary, doesn't necessarily indicate that the virus is infectious one, and it is not directly related to actually viral load. So, in another point is for asymptomatic healthcare provider actually can they can be permitted for what if they remain symptomless, but she or he has to wear face mask for 14 days at the facility at all time. And after, and precaution actually after getting 2 tests negative, either symptom-based strategy or test-based strategy or time-based must take precaution. That is when she returned or he returned to job, he must wear face mask for 14 days. I think, can you hear me?
Yeah, yes, madam. Madam, thank you so much for providing us such an important information. Okay, now I like to move on to Professor Ferdowsi Begum. Madam, you are the president of SAPOC and you are playing a vital role in this subcontinent. So my question for you, what is Pan-COVID registry and how Bangladesh be incorporated to this global sort of interaction?
And a very good, what should I say, good evening here, but maybe good afternoon.
Madam, শোনা যাচ্ছে না, একটু জোরে বলেন madam.
Thank you very much for inviting me. Can you hear me now?
Yeah, একটু জোরে বলেন madam. Speak loudly, madam, please.
First of all, thanks everyone for inviting me. And the question is very pertinent. South Asian Federation of Obstetrics and Gynecology is working since the COVID is in the picture. Basically, a few days back, about I think it's 1 month back, we had a web-based conference where we invited Dr. Leslie Reagan as one of the guests, and she mentioned about the Pan-COVID registry, and that's why we are sort of seeing the possibility of joining in that. Basically, the Pan-COVID registry, PAN means pregnancy and neonatal outcome. So PAN, pregnancy and neonatal outcome in COVID-19. So this is a global registry with women of suspected and confirmed SARS-CoV-2 infection in pregnancy and their neonates, understanding the maternal history to guide treatment and prevention. So this is being organized by Imperial College of London. And of course, there is ethical and other clearance from NHS as well. So the thing is, this is an open registry. Anybody in the world can join this so that we can sum up the data here. So if we think about the SAPOC region and other countries, basically it cannot be done through an organization. It has to be case-to-case basis. Like an organization has to have consent for that. So this is a very good, if we can sum up all the data, especially developed words, developing words, and so much data, if we can compile, that will be a very good one. But the thing is, we need ethical clearance from the country, from the institution. So that's important for research purpose, of course. But this is difficult to in a united way. So as far as I understand, if Bangladesh has to be part of any country of SAPOC region, has to be the part of this Pan-COVID registry, they have to have first show their interest in this. This is the open registry. Open means anybody can approach that. But after you approach that, you have to submit the ethical clearance from either from the country or from the institute. So Professor T.H. sir is here. We were discussing among the SAFOG bodies, and today we had discussed with him as well. And we have taken decision, and I think this is obvious, that it cannot be, has to be done country basis. And in Bangladesh as well, as we have, we may have difficulty to get a national ethical clearance. I think it should be individual institution basis. Say, as for example, BSNL. If you want to do that, you have to obtain ethical clearance from own institute. So that's in short about COVID registry.
Thank you so much, madam. Very new and very important information for all of us. So our last panel member, but not the least, Professor Tipti Rani Das. Madam, you are working as a chairman in the Department of Obs and Gynae, Bangabandhu Sheikh Mujib Medical University, and you have to face a large number of patients daily. So my question is, how can we triage the patient in labor ward so that early identification and prevention of transmission of coronavirus infection is possible? Mute হয়ে আছেন, madam. Unmute, please. Left side এর নিচে বাটনের unmute. Okay. Videoর পাশে, at the side of video, there is a button, mute. একদম হ্যাঁ, okay. I think we can hear you.
শোনা যাচ্ছে?
শোনা যাচ্ছে।
শুনে কি শোনা যাচ্ছে?
শোনা যাচ্ছে, বলেন। শোনা যাচ্ছে, শোনা যাচ্ছে।
First of all, I'd like to thank you, Dr. Jannatul Firdaus, for inviting me in this type of interesting international webinar. So your question is that how we'll go for trials in labor. So for trialing, actually 3 things are most important, I think. One important thing is the trials area. So all efforts should be made to limit the movement of the woman from one care area to another care area. As for example, from trials area to antepartum room to labor and delivery room. For this reason, I think the admission for delivery should remain in labor room. Secondly, who will be the designated person for trials? In our perspective, actually our junior doctor done this job. So how we can trial the patient? When the patient at first entry point, we ask asking, there have been fever or any respiratory symptom or any body ache or malaise, or have they had any contact with suspected or confirmed case of COVID-19? If the answer is not, in spite of this, we advise the patient for COVID test and just examine the patient whether the patient is an acute obstetric emergency or not. If there is no obstetric emergency, advise for COVID test, and counsel her for home quarantine and communication with patient. But if the patient having any acute symptom and acute obstetric emergency, then patient should be put into COVID dedicated labor room. So in trial, actually, we are done for go for one on COVID patient and another one for non-COVID and suspected case. As our load is actually selected a room close to the labor room and try to try the doctor by asking some question and then separate the patient, one for or priority basis. If the patient is in active labor, then transfer the patient to the labor and delivery room. If the patient is not in labor, stay home as home quarantine by telephone. Thank you.
Can you hear me?
Can you hear me? Hello.
We can hear you. We can hear you. শোনা যায়। Please continue.
Hello.
শোনা যায়।
শোনা যায়।
শোনা যায়।
So for trials, first we select trials room close to the labor room. So what the person, our designated person are a junior doctor. They are some question that like, do you have any fever symptom like so, just like this. If the patient having symptom mild or moderate symptom and there is no acute obstetric emergency, then we ask the patient to stay home quarantine and go for COVID test and communicate with us by telephone. If the patient having any obstetric emergency, then just management just like in labor and delivery protocol, just and if the patient is in symptom is severe one and patient is not in labor, then we help try to help the patient by multidisciplinary approach like the help from medicine. Junaki, please.
Okay. Thank you so much. Thank you, Professor Tipti Rani Das. Actually, we are near the end of our session. Thanks to the honorable delegates who blessed us with their presence. And I would like to convey special thanks to my co-moderator, Dr. Ashfaq, who has taken all the pain to make this webinar successful. I like to mention that Dr. Ashfaq, along with his team, took initiative to help the doctor of Bangladesh. He procured and donated a good number of PPE that has already been distributed to different hospitals, including Dhaka Medical College Hospital, Bangabandhu Sheikh Mujib Medical University, Sheikh Russell Gastro-Liver Hospital, and also in some private clinics. Thanks, Dr. Ashfaq, for being with us. So, Dr. Ashfaq, you are requested to give your remarks before vote of thanks, which will be delivered by Dr. Khushi Jahan Maula, President-elect, Gynecological Oncology Society of Bangladesh. Dr. Ashfaq, please.
Thank you, Professor Firdaus. It's an honor for me to meet all my teachers whom I had the opportunity to work for a few years in Bangladesh. And again, the few take-home message from today's meeting. Number one, that for gynecology, we need to work as a regional, you have to set up some regional areas where as a BSc MIMU cover one area of the city and the other unit should actually listen to you. Like in any big cities, you have a regional referral center that take care of the other hospitals. So it comes under the umbrella of few regional centers and you can follow that one. Data collection and audit. I'm so pleased that PAN audit is going on because we need it for everything. We will not be forgiven by our juniors in 20 years' time if we look at them and say, I don't know what happened at that time. People died, and I don't know why they died. So we need to know what happened, what medicine I gave, what complication they had. Somebody in every hospital just do it. It doesn't need to be a research. It could be an audit. And that is one thing. My request to Professor T.A. Chaudhary to look at whether, like it happens, a fast-tracking and a research approval, which can be applied across the country. So you don't need individual institute to apply for R&D approval. Video and telephone consultation will become a norm, but mainly for the follow-ups for cancer patients. Looking at whether the procedures can be done under local anesthesia rather than general anesthesia. So loop, hysteroscopy, whether that can be done. We also found out that rapid access clinic or one-stop clinic would be more helpful in this situation. And we also learned that hypofractionated chemoradiotherapy would be an option during this time. With all that information, I just want to thank you all again, all my colleagues from UK, but all my seniors from Bangladesh. I can see Professor Chaudhary is raising her hand. Professor Samina Chaudhary, I give a microphone to you.
Thank you, Ashfaq. Can you hear me, Ashfaq? Thank you very much for the nice webinar session, and I want to congratulate all of you for attending this interesting session. And though it is a long session, but still I think that we are not tired. And one important issue is that what I learned from this webinar, that there is no doubt that this is in UK, one of the best health system existing in UK. And what you can do it easily, but it's like a dream to us. We have to face many challenges, and you know that when you are in this country, you know that. But still, we are very happy that you have given many new information, and I think we will continue it because we need to develop some system. As for example, integrated digital system and with multidisciplinary approach that we can do, but we need some guidance. I think that is one important learning for us. About another thing is that about the testing, you have got enough testing facilities, but we have got very limited testing facilities, and only we are doing RT-PCR, but we are not on the quick test and antibody test. I don't know when it will come, and this I feel it's a very important one, so that we can develop our some program with you, so that we can develop this in this country. And I must say thanks to all of you for the excellent presentation, and special thanks to Ashfaq for taking all the trouble, and Dr. Jonaki, Ferdowsara Jonaki, and my special thanks to our junior colleagues Rehana, Nadia, and also my other colleagues in Bangladesh. I must say thanks to you, and we'll work together and go for the future direction. We'll be together. Thank you very much. And I also want to thank to ACI. They have helped us in this webinar. Thank you very much. Rehana, you want to say something? Rehana, I can't hear. Unmute it.
We like to thank you all, madams, for looking after yourself and looking after the country. I think you people are working hard, and I know, coming from Bangladesh, how difficult it would be to, control this pandemic. We are, as you say, we are very lucky to be in NHS, which is a very structured system. but my heart goes up to you to say thank you, because our parents are there, our families are there, and you are actually looking after the whole country. So really big thank you to you all.
And I am very much sorry that there was so many interruptions from my side. There is some accident, so I couldn't contact many time with you.
It's okay. It's expected from being Bangladesh. It's fine. Be part of it. Thank you.
Hello, Janaki.
Dr. Ashfaq, vote of thanks. Now, Madam.
I'm waiting for you.
Professor Maula, who is the President-elect for Bangladesh Gynecological Oncology Society, to give the vote of thanks and conclude the session.
Thank you, sir. I'm waiting for your last event. I'm Dr. Khurshidjan Maula. I am giving the responsibility for giving thanks for you all. In the women's health in Bangladesh during COVID pandemic and beyond this. This is a pleasure and privilege to me to be here in this program of women's health during the COVID session. I will not take much more time of you because everybody is tired. There is a very vivid discussion about the COVID in women's health. Very interesting and very lengthy discussion. We are very much helpful by this lecture, by this from home and abroad. It is our pleasure. Present in gynecology department and for the ODSB allowed. Firstly, I give my thanks to DOSB Chairman Professor T.A. Chaudhary for his excellent presence in this session, and ODSB of Professor Samira Chaudhary, a participant from UK and Bangladesh. All moderators, they learned hard and lot, and the organizers of ACI with all their staffs. I cannot make delay. Thank you all for your kind support and excellence.
Thank you.
Okay.
And thank you, Professor Firdaus. Though it's difficult to call you Professor.
Oh,
Firdaus
Dr. Ashfaq.
Yeah.
Dr. Ashfaq. Finally, the webinar is coming to end, but we want to hear from our sir, Professor T.A. Chaudhary, sir, the concluding remarks from you, sir.
Can you hear me?
Yes, sir, we can hear you.
You have heard me so much time. Only thing I can say that this was an exhaustive webinar. I would have been happy if I could divide this into 2 different webinars in 2 different days. But sometimes it is difficult to get all the people together. So I think we took this opportunity. So if somebody has got extra tiredness, please excuse us. But I think we have learned a lot from our discussions, and it is always better to talk, because what we can learn from each other in the practical field rather than going through a theoretical lecture. I think organization was good in the form of a question and answer rather than one man doing a presentation. So I would like to thank all my junior colleagues. Some of them possibly are not even medical students when I was a consultant here, much too senior. But in any case, this younger generation is coming up, and I'm glad to see that in UK, you are also working very hard and with great reputation. Keep it up. Thank you.
Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.